بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم تسليما كثيرا. أعزائي أبنائي إخواني الطلبة، يتجدد بكم اللقاء في محاضرة جديدة من سلسلة محاضرات Ophthalmology Made Easy. محاضرة اليوم ستكون عن important subject which is the keratoconus. We will give a comprehensive guide and updated review on keratoconus. This is a very important subject as far as the visual function is concerned, as well as that it affects a young productive generation of patients. And also because it is a very huge subject, I divide it into two lectures. The first lecture we will discuss about the definition and the classification of keratoconus, and we will give a historical prospect about the evolution of the name of keratoconus, and also we will give the quick review regarding the clinical signs and symptoms that patient will suffer with keratoconus, and we will give the diagnostic tools that you help us to diagnose keratoconus, and at the end we will revise the early detection and progression displays and the staging of keratoconus. In the second lecture, we will discuss the different treatment modalities available, starting from the simple objective refraction and the glasses, and contact lenses, the cross-linking and the intracorneal rings, and the use of laser in the treatment or in the management of patients with the keratoconus, and end up with the use of keratoplasty in the management of keratoconus. And we will give approach to a case of keratoconus, how you tackle the case, and how you make a plan for you to manage this case. I hope that you will enjoy this lecture, and we will dive deeply and go and see what's there. بسم الله الرحمن الرحيم. نبدأ المحاضرة الأولى في comprehensive guide about keratoconus. First, we'll start with the epidemiology, classification, and definition of ectatic eye diseases. Now we come to an important section of this lecture, which is the epidemiology. Now, nobody can answer you what's the overall the prevalence or the incidence of keratoconus all over the world, although there are various studies and there's a huge diversity between the result between different centers and different studies and different locations. And this might be attributed to the multifactorial etiology of the disease. And there are a lot of variables that affect the incidence and the prevalence of the disease, and even the geographical distribution and the genetic factors. All these plays an important role in the incidence and the prevalence. Another important factor is the huge advancement in the detection of keratoconus. So previously they were dependent on certain tools to diagnose keratoconus, but recently with the era of tomography, now the definition and the prevalence has been hugely changed because of the advancement in these techniques. For example, you can see this is one study that follow over 48 years the epidemiology of keratoconus, and they found this is at 1986 that the prevalence of keratoconus is 1 in 2,000 cases. And as I said, that this most of the doctors, they believe that this figure is not an accurate figure, because nowadays with the recent studies suggest that the prevalence is much more than this figure due to the introduction of modern and highly sophisticated corneal imaging techniques, and the better understanding of the geographical distribution and the ethnicity plays an important role in the prevalence of the disease. So these figures predates the occurrence of tomography, and nowadays, due to the huge paradigm shift in the technology for the early detection and also in the definition of keratoconus, so the prevalence is much more than this figure. But globally, there is a generalized consensus that around 1.38 per 1,000 population is the overall prevalence or incidence of keratoconus. However, this is not an accurate figure, because this depends on the geographical distribution and other variables, as I will explain later. What's the other factors that plays a role in the incidence and the prevalence of keratoconus. Now, in Libya, the prevalence and the incidence of keratoconus is not as extensively documented as in other countries, and there is little insight about the incidence and the prevalence of the disease available from the studies done in adjacent countries like in For example, in one study done, they discovered the prevalence to be 2.3 per 1,000 population. Another similar study conducted in Egypt, they found the prevalence is 11.2 per 1,000 population. So due to the similarity in the atmosphere and the genetics and everything between these two adjacent countries, so Libya will falls between these two figures, but this is a alarm for all the responsible people and for the junior doctors who are interested in this subject to conduct or establish the prevalence and the incidence of keratoconus in our country. And this is very important to utilize what available technology and the advancement of the technology with the availability of the pentacam and the tomography for determining the prevalence and the incidence of keratoconus in our country, so that we can set up a early detection program that will implement the early treatment so that we can arrest the progression of the disease. Another important epidemiological data as far as keratoconus is the sex predilection. There are many studies shows that there is some male predominance, and this can be attributed to the ultraviolet exposure. Some other studies shows female predominance due to hormonal changes, but generally there is agreement that there is no significant sex predilection among different genders, and usually equal between both sexes. Another point is, as I said in the definition, it is a bilateral disease, but usually it presents asymmetrically. So it can present unilateral in one eye and then it progresses to the other eye. Another thing is the age of presentation. Now, all the studies shows that the usual age of presentation is between 20 to 30 years. But now with the paradigm shift in the imaging techniques of the cornea, there is a separate entity which is known as the pediatric keratoconus. So keratoconus can present in a younger age and have a special course and special activity, which is the pediatric keratoconus. Another thing, the ethnicity. Many studies shows that it is very common in Asians as compared to Caucasians, also in blacks as compared to Caucasians or whites, and also in Africans and Middle East is much more than the Caucasians. Another thing is the family history, and this can be explained by the genetic background of the etiology of this disease. So it is found that a positive family history is seen in 5 to 20% of the cases, and this is very important to be related to the genetic background of this disease. Another thing is the role of diabetes. Some studies shows that diabetic people are much more prone to the keratoconus. However, there is general agreement that diabetes is immune and protective against keratoconus, and this can be explained due to the glycosylation that happens in diabetic patients. And this glycosylation, the collagen fibers in the stroma, can protect against the occurrence of keratoconus. The word keratoconus is a combination of a Latin word and a Greek word. Kerato means cornea and conus means horn or bulging of the cornea. So it's a combination of Latin and Greek word keratoconus, and it describes a slowly progressive stromal disease that lead eventually to thinning of the cornea as well as bulging of the cornea. As you know that the cornea is the most anterior part of the outer coat of the eye, and this represents a external lens of the eye that's focusing the rays towards the retina. Now, this normal shape of the cornea is usually spherical in shape, and we will know later by topography that it is prolate in shape. And once the disease progress and thinning increase, so there will be distortion of the shape of the cornea. And as a result of this, the image will be distorted, and the introduction of the refractive error will start as initially as myopia, followed by astigmatism that can be corrected to some extent Then once the disease progresses more, there will be an irregular astigmatism and also accompanied by irregularity of the surface. And this will lead to a significant distortion of the image in the magnitude as well as in the quality. So keratoconus is a slowly progressive non-inflammatory disease from clinical point of view that lead to the thinning and bulging of the cornea, and as a result will lead to a significant degradation of the image quality, and the patient will complain of poor vision, and this poor vision will affect his quality of life. So this is briefly the definition of keratoconus. Now, after finishing the general definition of keratoconus, but for us as a ophthalmology practitioner and specialist in the cornea clinic, we need more details about the different types of definition of keratoconus. Now, the cornea specialists, they still further subdivide the definition of keratoconus into a clinical definition and subclinical definition or subclinical keratoconus. Now, the clinical definition based on the clinical signs and symptoms that you will see on the patient when he came to you to the clinic. You'll find drop in the visual acuity. You will find clinical signs seen by slit lamp, and you will find thinning and bulging of the cornea. And according to this, it is defined clinically as a chronic bilateral asymmetric progressive disease. So it is a chronic non-inflammatory disease. And this is based on the clinical signs. So clinically, you will not find inflammation. However, you will see when we'll speak later about the pathogenesis of keratoconus that at the molecular level, there is evidence of low-grade inflammation. But clinically, there is no clinical inflammation. So we generally say that it is a non-inflammatory progressive chronic disease. And it is a bilateral disease. And this is very important because later on, we will speak about the form of Rus keratoconus. We will understand the importance of this bilateral. So keratoconus is never unilateral disease. And if you find a unilateral ectasia, it might not be a primary keratoectasia. It might be secondary to trauma or thinning or inflammation due to other cause. But for primary ectasia, namely keratoconus, it is a bilateral disease, but sometimes asymmetrical, that it presents in one eye before the other eye. This is very important. And it should be progressive, that if you diagnose the patient as having a keratoconus, it will be a progressive. It will not be stationary. So it has a progressive disease. And it will be only stationary if we interfere by cross-linking or the patient get auto cross-linking by after the age of 40 years. Otherwise, it is a progressive disease and also is characterized by underlying biomechanical abnormalities in the cornea. Now, what's the subclinical definition or the subclinical keratoconus? This is a variety of keratoconus that can be diagnosed by topography only. Clinically, the patient completely normal. He has a normal visual acuity and even 6/6 visual acuity, but the topographic data are abnormal. Now, the subclinical keratoconus is subdivided into two categories. It can be a form of Rus keratoconus or it can be a keratoconus suspect. Now, I will explain this so that remove the confusion from this terminology. Now, the form of Rus keratoconus, as we said that keratoconus is a bilateral disease. If you find a patient with documented unilateral keratoconus in one eye and the other eye is completely normal topographically and clinically, so we cannot say that this is a normal eye because keratoconus never is a unilateral disease. This is named as a very asymmetric ectasia or form of Rus keratoconus. So form of Rus keratoconus is a normal eye topographically and clinically for a contralateral documented keratoconus. This is known as form of Rus keratoconus. However, sometimes you find a very clearly documented keratoconus in one eye and the other eye has topographic evidence of abnormality in the form of abnormality in the elevation map, especially the posterior elevation map, with or without changes in the curvature map, with or without changes in the pachymetry. But we cannot say that this is a keratoconus. That's why this entity is placed in this group form of Rus keratoconus. And I will tell you why we group this entity separately from the clinical keratoconus. Now, the other subtype of the subclinical keratoconus is what's known as keratoconus suspect. In this patient, the numerical data for topography and tomography and the corneal hysteresis or corneal biomechanics, they are abnormal, but they are not abnormal to the extent that we say that this is a keratoconus, and they are not normal to the extent that we say that there is no keratoconus. So it is an in-between, in the gray zone, in between the normal and abnormal. So this is known as keratoconus suspect. Now, this entity of subclinical keratoconus is very important because these people might not progress to keratoconus if we don't touch them. This is important because if we diagnose them as subclinical keratoconus, we need just to follow them. Some people, they will progress to evident and clinical keratoconus, and some people, they will be stationary for life unless we interfere with laser vision correction. So this is important for screening for laser vision correction. If we see this patient, better not to do laser for them. But this doesn't mean that they have a keratoconus. They might be stationary and there will be no progression. Because keratoconus, when you say this is a stigma, the patient will have a progressive disease. So we cannot say that they have keratoconus, but we say that they have keratoconus suspect or subclinical keratoconus. This is very important. Now, to explain, to understand this in details and remove the confusion, as I said, that this diagram shows this is the normal patients or normal population, that there is no keratoconus in this group. And this group is, or the graph represents the people with keratoconus. Now, in between these two groups, we have the subclinical keratoconus. It can be either in the form of rust keratoconus or very asymmetric ectasia. That's one eye is completely normal and the other eye has evidence of keratoconus. And this makes the confusion that usually diagnosed as a false negative, that the patient is normal, but this is a false negative because they will have keratoconus later on, because sometimes they will progress because by definition keratoconus is a bilateral disease. There's another entity, as I said, that the data for topography, tomography, corneal biomechanics, corneal hysteresis, they are borderline, in the border zone here, or the gray zone, that's in between the abnormal keratoconus values and the normal corneal values. So they have abnormal data that we cannot say that they have keratoconus, but they have abnormal data. So these people are known as keratoconus suspect. As I said, some of them, they might progress to keratoconus, and some of them, they will be stationary. So the form of rust keratoconus and the keratoconus suspect is a varieties of subclinical keratoconus. Of course, the keratoconus suspect, usually we make a false positive. Sometimes by our investigation, we make a false positive result that they have keratoconus, but they are not. They are subclinical cases. So subclinical keratoconus has two entities: the form of rust keratoconus and keratoconus suspect. Now we come to one of the important aspects of this lecture is to understand how we classify the ectatic eye diseases. So one of the intended learning outcomes of this lecture is to understand the classification, because this is very important in understanding the different definitions and the different terminology that we will speak about them later. Now, the ectatic eye disease is broadly classified as based on the etiology or based on the topography. Now, the etiology concentrates in the cause behind the ectatic eye disease, and the tomography based on the tomographic appearance on tomography. So the etiological classification, as I said, based on the etiology, it can be further subdivided into a primary causes or secondary causes. The primary causes in which the exact etiology is not known is idiopathic, and the secondary ectatic eye diseases is due to iatrogenous causes. Commonly, it's known also as iatrogenous ectatic eye diseases. The primary ectatic eye diseases can be further subdivided into different types, like the keratoconus, the keratoglobus, the pellucid marginal degenerations, Tyrrell's marginal degenerations. All these are known as primary ectatic eye diseases. and the secondary ectatic eye diseases mainly due to heterogeneous causes, that's post-surgical, post-refractive keratotomy or intacs, I mean radial keratotomy or intacs or post-PRK or LASIK corrections. Now, all of these are beyond the scope of this lecture. We will concentrate mainly on the primary cause due to keratoconus. Now, our study in this lecture, we will concentrate in the keratoconus as a cause of ectatic eye disease. Now, if we come back to the other level of classification, which is based on the tomography or the tomographic classification. This tomographic classification, as I said, it classifies the ectatic eye disease based on the appearance on the tomography or topography. To understand the tomographic classification, we need to understand certain terminology, which is the form of rust keratoconus, the keratoconus suspects, the pellucid marginal degenerations, pellucid-like keratoconus, and keratoglobus. Now, the form of rust keratoconus, in which there is unilateral keratoconus, definite diagnosis of unilateral keratoconus in one eye, and the other eye shows mild abnormalities in the topography or normal eye. But the abnormality in the topography is not significant to fit to a keratoconus. This is called very asymmetric ectasia or unilateral ectasia or form of rust keratoconus. Now, in keratoconus suspect, we have no definite diagnosis of keratoconus, but both eyes shows abnormality in the topography, or one eye is completely normal and the other eye shows abnormal topography, but still not significant to diagnose keratoconus. Now, in the pellucid marginal degeneration, this is a separate entity of ectatic eye diseases, also known as peripheral ectatic eye diseases, unlike keratoconus, which is central or paracentral. And it has a pathognomonic features in the topography in the form of crepe claw or kissing dove in the curvature map and the pill sign in the pachymetry map. Both should be present to diagnose pellucid marginal degenerations. And pellucid marginal degeneration characterized by the absence of the scarring or opacities in the cornea. That's why it is named as pellucid. Now, the pellucid-like keratoconus, it is a keratoconus, but it has a appearance in the curvature map like the kissing dove, which is similar to the pellucid marginal degeneration, but it has no pill sign in the pachymetry map. This is very important. Now, the keratoglobus characterized by generalized thinning and generalized ectasia of the cornea in the topography. So this is generally the classification of ectatic eye diseases based on the topographic appearance. As I said, we will concentrate only in keratoconus. Now here I will elaborate more about the difference between form of rust keratoconus and keratoconus suspect as I demonstrate here in this presentation. In the form of rust keratoconus, as I said earlier, that you have one eye with definite clear-cut keratoconus and the other eye is normal or shows mild abnormality that not fit to be a keratoconus. In this case, this is named as form of rust keratoconus because, as you know, keratoconus is a bilateral disease, and if we have a unilateral eye is a definite keratoconus, so most likely the other eye will progress later on to a keratoconus. So this is known as form of rust keratoconus, and this patient need close follow-up because he might develop keratoconus later. Now, if you see this example for the left eye and the right eye, you can see clearly that the left eye shows a hot spot both in the curvature map as well as in the elevations map. So this is named as red or red. So also in the pachymetry map. So this is definite keratoconus. I will explain later about the principle of red on red. However, when you look to the other eye, you can see the redness in the curvature map, but the blue color in the elevation map. So this is named as red on blue. So this is normal eye, just only high astigmatism. And this is clear-cut definite keratoconus. So this is a form of rust keratoconus. Now, on contrary, if you have a normal eye and the other eye shows mild abnormalities, or you have in both eyes are abnormal topographic finding, but they are not fit to be definite keratoconus. So these cases are named as keratoconus suspects. And keratoconus suspects not necessarily they will progress to keratoconus, but we should pick up them so that we don't do laser correction for them, because most of these patients are detected while they are coming for laser vision correction, and accidentally we discover that they have abnormal topography. So these patients are at risk for having iatrogenous ectasia if they did laser vision correction. But if they left untouched, they not necessarily will progress to a definite keratoconus. Now we come to an important differential diagnosis for keratoconus, which is named as pellucid marginal degeneration. Now, pellucid marginal degeneration belongs to the ectatic disorders that has primary origin, but it differs from keratoconus that it has peripheral origin. That's usually the thinning and ectasia in the periphery. However, in keratoconus, it is central or paracentral. Another thing, the presentation, usually in the pellucid marginal degeneration, they have older presentation between the third to fifth decade, unlike in keratoconus, which is during from puberty and in adulthood. So another thing that by the name pellucid means clear. So the cornea usually clear in patients with pellucid marginal degenerations. They don't have scarring, they don't have Rossetti sign or Fleischer's ring or the Voges stria, or the incidence of acute hydrops is not there as in keratoconus. So the cornea is very clear in patients with pellucid marginal degeneration. They present usually with high significant against the rule astigmatism. Now, among the topographic difference between the pellucid marginal degenerations and keratoconus in the curvature map, this is the typical sign of the kissing dove or the butterfly or crab claw appearance. And this is seen in the curvature map, although it is not pathognomonic for crab claw, because can be for a pellucid marginal degeneration, because can be seen also in pellucid-like keratoconus. Now, the pathognomonic sign is seen in the pachymetry map, which is known as the pill-shaped sign, and this should be evident only with large-scale map, that you should take a 12-millimeter map so that you can see the peripheral part of the cornea, and you can clearly see the thinning in the far periphery of the cornea. This is pathognomonic for pellucid marginal degenerations. The other sign, which is seen in the elevation maps, known as the Pierre-Pili side profile. Now, in the Pierre-Pili, it means that the bulging of the cornea is above the thinning. This is the characteristic for pellucid. However, in keratoconus, the bulging and the thinning usually coincide, so that the apex of the cone is coincide with the thinnest point of the cornea. However, in pellucid, the bulging lies above the thinnest point of the cornea. As you can see here, this is the bulging area, and the thinnest point, you will find it here in the far periphery. So this is called Pierre-Pili side profile. So for you as a postgraduate student, now you should memorize these signs. These are very important, that the Pierre-Pili side profile in the elevation map, and the pill sign in the pachymetry map, and the crab claw or the butterfly is seen in the curvature map. You should not mix between these names. And as I said, that the pathognomonic sign is the pill-shaped sign in the pachymetry map. Another thing that, as you can see here, this is similarly the kissing dove, and there are another 3 spots in the anterior and posterior elevation mass. This is called a 3-point touch sign, also seen in pellucid marginal degeneration. Another difference or diagnostic difference between keratoconus and pellucid marginal degeneration is the progression thickness profile, or the percentage of thickness increase that's seen in this display. As you can see, that the progression profile of the thickness of the cornea from the central part to the periphery, if it dropped down significantly less than the 6 millimeter zone, this is suggestive of keratoconus. As you can see here, this is the percentage of thickness increase. So this patient falls in below the 3 or the lower limit of normal. This is the lower limit of normal, but this is suggestive of keratoconus. However, in patients with pellucid marginal degenerations, because the far periphery is much more thinner than the center, so you find the progression thickness profile is straight or sometimes reversed. So this is characteristic of pellucid marginal degeneration. Of course, with the significant against the rule astigmatism, you will find it. Another thing, of course, and the last thing is the OCT. By the OCT, you can definitely see the peripheral thinning of the cornea, which is very suggestive and characteristic of pellucid marginal degeneration. Now we come to the second section of this lecture, which is a brief historical prospect regarding keratoconus and the terminology that's used during a long period till we reach now to the term keratoconus. Starting with a brief historical prospect regarding the keratoconus, and the start from the beginning starts from Germany at 1748 by a professor Burchard Mouchard, who described it as a Staphyloma diaphanum. He uses the term Staphyloma diaphanum to describe and observe this case of abnormal shape of the cornea. Then at 1854, John Nottingham from the United Kingdom, he describes or he uses the term conical cornea to describe this condition, and he published a paper about this as a conical cornea. And then at the end, at 1869, John Horner is a Swiss physician who first uses the term keratoconus. Up till now, we use this term to describe this disease, and this John Horner is a famous doctor that he is the owner of the who describes also the Horner syndrome. So they started from Germany as the Staphyloma diaphanum. Then Britain, they first time they used the term conical cornea, and end up in the Swiss physician and give the name as keratoconus. This is a medical school in Poland. They conducted a study, and they asked some of the selected samples of the population, and they asked them to select one of these pictures that resemble the way how they rub their eyes. They found that 75% of the normal people who are not having keratoconus, they choose between 1, 2, 3, and 4. But number 1 is the most likely one that is very minimum trauma to the eye. However, when they apply the same question to the population of keratoconus people, and they ask them to choose one of these pictures, how they rub their eyes, they 50% of them, they choose the picture 5, 6, 7, 8, and number 8 is the most common one in patient or populations with keratoconus. So you can see that by the way how you rub your eyes also it will significantly impact the risk of having keratoconus. You see in number 8 he's using his knuckles to rub his eyes, and this create a major trauma to the cornea, and this will initiate the decompensation of the cycle of decompensation of the cornea, and this can lead or trigger to the factors leading to keratoconus. Now, if we want to speak about the associations of keratoconus, we have two associations. One related to the eye itself or eye disorder itself, like vernal spring catarrh or the presence of aniridia, ectopia lentis, Leber's congenital amaurosis, and retinitis pigmentosa, as you can see here in this picture. And this is spring catarrh, and this is ectopia lentis. And also there is a systemic association associated with systemic diseases like Down syndrome, Turner syndrome, Ehlers-Danlos syndrome, Marfan syndrome, atopy, osteogenesis imperfecta, and mitral valve prolapse, as in Marfan syndrome. As you can see, this is Marfan syndrome, and this is the osteogenesis imperfecta. And people with syndactyly and polydactyly, and this is Down syndrome. The main important thing is the presence of rubbing. Significant eye rubbing in patients carries a very high risk for developing keratoconus. So this is the main associations of keratoconus that we should keep them in mind while we are assessing a case of keratoconus. Now we come to the third section of this lecture, which is the pathogenesis of keratoconus and the cycle of corneal decompensation. Now, to understand the pathogenesis of keratoconus, we have to go quickly through the lamellar arrangement of the collagen fibers and the lamellae within the stroma, and understand the exact corneal structure. As you know that the resistance of the stroma to the transverse shear and strain is highest in the anterior stroma, and decrease as you go deeper in depth. So the anterior stroma more resistant and more stiff. And also it is now a fact that the anterior layer of the cornea have more mechanical stiffness due to more what's known as interwind collagen fibers organization. In the next slide, I will explain the meaning of the interwind collagen fibers arrangement. Now, these collagen fibers are not simple interwoven or interlaced as was taught before, but it is an interwind arrangement, and this offers the stroma, especially the anterior stroma, the mechanical stiffness and resistance to shear and strain. Another thing is that the layers of the stroma are perpendicular to each other, but at the same time parallel to the surface and strong anteriorly and compact centrally. So the center of the cornea is more compact and more strong than the periphery, and the anterior stroma more stiff as compared to the posterior stroma. And all this plays an important role in the pathogenesis of keratoconus. Whenever there is any abnormality in the cornea that will lead to keratoconus, we will note that there will be a derangement in this special arrangement of the stroma. So as I said, that the anterior stroma is more stiffer and more resistance to shear and strain as compared to the posterior stroma, and also the central stroma more compact and more stiff as compared to the peripheral stroma. And this is explains why we note that in keratoconus or also in patients who underwent cross-linking that we have to reach to the deeper stroma to make it more stiffer because the anterior stroma is more stiffer than the posterior stroma. Now, in this slide, I will explain the meaning of the old fact that the lamellae of the collagen fibers in the stroma are interwoven like this appearance. However, recently it is discovered that it is not like this interwoven appearance, but it has what's known as interwind appearance, especially in the anterior part of the stroma and in the central part as compared to the periphery. So this offers the cornea and the stroma more stiffness in the anterior part of the stroma as compared to the posterior part, and this might explain why keratoconus, the first place for early detection of keratoconus, appears in the posterior surface of the cornea or adjacent to the posterior stroma. However, the anterior stroma is very stiff and very tight because of the compactness and increase the mechanical force for against the shear and strain in the anterior stroma. So this old thought that the lamellae are interwoven is not valid anymore, and the stroma has an interwoven. For example, this is the anterior part of the stroma. You can see that it is very tight and very compact as compared to the posterior part of the stroma, which has space in between the fibers. And this also explains why in what's known as in Dalt procedure in Anwar big bubble technique, that the superficial heavily interwind collagen fibers, as you can see here, show only emphysema. When we inject air, we will not be able to separate between the lamellae of the collagen fibers of the stroma, and you will find only emphysema. However, as you go more deeper toward the desmids or the predesmids area, that's the Duas layer, you will find the big bubble and the separation between the stroma and the desmids area or the predesmids area. So this is of very important anatomical application. So when you want to do DALC with a good big bubble, you have to go more posterior to the stroma and avoid to come to the anterior part of the stroma. Now in this slide, I will show the pathological changes that happens in the cornea in a patient with keratoconus, starting from the loss of the transverse and coring lamellae between the epithelium and the loss of the keratocytes or the apoptosis, and also the changes in the extracellular matrix and in the Bowman's layer. All these together will lead to thinning and bulging of the cornea and lead to separation between the lamellae and reduction in the stromal lamellae, and increase the slippage between the lamellae and also the apoptosis and loss of keratocytes. So this is a quick overview about the pathogenesis of the keratoconus and what are the changes that happens in the cornea at the level of the epithelium, Bowman's layer, and the stroma, the keratocytes, extracellular matrix, as well as We understand the normal arrangement of the collagen fibers and the intertwined appearance of the lamellae of the collagen fibers in the stroma. Now we come to an important section of the pathogenesis of keratoconus. Now, as you know, the pathogenesis of keratoconus is multifactorial. There is a contribution from genetic factors and environmental factors, hormonal factors, and biomechanical factors. So the exact pathogenesis is not known, but it is a multifactorial pathogenesis. Now we'll start to say some words about the genetic factors and the genetic predisposition. Now, the role of genetics in the expression of keratoconus is well known and well observed since long time. However, the exact genetic sequence that is responsible for keratoconus is not well identified, although there are a lot of various loci has been incriminated as a cause for keratoconus, but the exact location of the genetics responsible for keratoconus is not well identified, and even the molecular basis for the expression of this genes is not well recognized. However, the association of consanguinity and the monozygotic twins, all this raises the suspicion of the genetic role in the pathogenesis of keratoconus. Also, the relation of keratoconus with certain genetic diseases like Down syndrome and Leber's congenital amaurosis and Ehlers-Danlos syndrome. All these make the relation and the link between genetics and keratoconus is well established. However, as I said that the keratoconus is a multifactorial disease, it is not just only the genetics. Perhaps the patient will have a genetic predisposition super added with certain environmental or hormonal factors that lead to the full-blown picture of the keratoconus. However, the genetic susceptibility should be there before the expression of keratoconus. Second variable, which is important in the etiology and the pathogenesis of keratoconus, is the environmental factors. Now we come to the second risk factor for the development of keratoconus, which is the environmental factors. There are certain environmental factors that plays a major role in the pathogenesis of keratoconus. And the top of them is the eye rubbing. Now, the eye rubbing is considered to be a very, very significant risk factor for the etiology of keratoconus, responsible or seen in 60 to 80% of patients with keratoconus. And its association with ocular allergy has been seen in 10 to 27% of patients of keratoconus. And also among the environmental factors is the geographical distribution or the geographical pattern, as keratoconus has been seen mainly in hot and dry climates. So what's the mechanism of eye rubbing that will initiate the keratoconus? It is claimed that by the process of eye rubbing, we initiate some sort of mechanical trauma. This mechanical trauma to the cornea will initiate a low-grade inflammations and the release of certain mediators of inflammation that lead to increase the apoptosis of and activation of oxidative damage to the collagen in the stroma, and increase the degradation and decrease collagen synthesis. All these factors will lead to decrease in the integrity of the collagen in the stroma and influence the biomechanical properties of these corneas and lead to thinning of the cornea and then bulging and ectasia. Usually, we used to define keratoconus clinically as non-inflammatory progressive bilateral disease. However, in the molecular basis, on the molecular level, there is a low-grade inflammation. Clinically, there will be no signs of redness or inflammation or anything, but at the molecular level, at the level of the cornea and the collagen fibers, there is a low-grade inflammation and is initiated by the eye rubbing, and this inflammation will lead to the apoptosis and degradation of the collagen of the stroma. Now we come to the third important variable responsible for the etiopathogenesis of keratoconus, which is the biomechanical variables. Now we come to the third important risk factor in the pathogenesis of keratoconus, which is the biomechanical inflammations or biomechanical changes that are seen in the cornea in a patient with keratoconus. As I said before, that there is a low-grade inflammation seen in patients with keratoconus, which is initiated by atopy or by eye rubbing. And this atopy or eye rubbing will activate an oxidative pathway and initiate an oxidative stress at the molecular level or at the cellular level. And this will stimulate the immune cell activation and the secretion of mediators of the inflammations. And these mediators of inflammation, namely the cytokines, which is has been documented to be present in a high concentration in the tear of a patient with allergy and patient with keratoconus. This will alter the expression of the extracellular matrix and the collagen proteins in the cornea and increase the activation of the proteinase enzymes and decrease the inhibitors of the proteinase enzymes. And all of these will lead to apparent remodeling of the extracellular matrix and abnormal collagen formations and abnormal cross-linking between the collagen fibrils. All these will lead to a change in the biomechanical properties of the cornea, leading to weakness of the cornea, and hence will lead to subsequent bulging of the cornea. So the hypothesis that there is a low-grade inflammation initiated by the presence of allergy and by the rubbing of the eye, and also in the presence of genetic susceptibility. This will initiate immune inflammatory inflammation, namely the release of cytokines, and this will lead in turn changes in the expression of the genes for the extracellular matrix and collagen. This is one of the etiologies or the theories behind the etiology of keratoconus is the biomechanical theory. Now we come to the fourth variable, which is responsible in the pathogenesis of keratoconus, which is the hormonal factors. As you know, hormones, especially estrogen, plays an important role in the pathogenesis of keratoconus. Now we come to the fourth point in the pathogenesis of keratoconus, which is the hormonal etiology and the hormones that are responsible for the pathogenesis of keratoconus. As I said before, that it is a multifactorial disease with a genetic predisposition. However, there are various variables playing in the background, so that will lead to expression of keratoconus. Now, the incriminated hormones in this regard is the estrogen, progesterone, and thyroid hormones. And the reason for that they note the association of puberty with the occurrence of keratoconus and association of puberty with these hormones, and also the increased estrogen and progesterone receptors has been seen in a patient with in the cornea of a patient with vernal keratoconjunctivitis. And also the corneal thickness and the biomechanical strength is affected by the menstrual cycle. There are some studies done on the changes of the cornea during the menstrual cycle, and they found significant change. And also the association of the raised T4 level in the tears of patients with keratoconjunctivitis. So these are the main three hormones that has been incriminated in the pathogenesis of keratoconus, and the reason might be due to increase in the proteolytic enzymes, as this has been documented during pregnancy. That's why in a patient with keratoconus and planning to get pregnant, better to do counseling with these patients. And if they have keratoconus, you need to stabilize the disease before giving the permission to the patient to get pregnant, because there is significant progression during pregnancy, and this activation of the proteolytic enzymes will lead to stromal thinning and subsequent ectasia. Okay, this is an important message I would like to remind you as a postgraduate student to understand from this talk that the etiology and the pathogenesis of keratoconus, especially the primary ectasia, is a multifactorial disease based on the genetic susceptibility and predisposition, and is triggered by acquired factors, which is the environmental factors in the form of rubbing or allergy, also the presence of underlying hormonal disturbance, and of course the presence of low-grade inflammation at the molecular level. All these plays an important role in the etiology and the pathogenesis of keratoconus, and should be kept in your mind while you are dealing with your patient. Now I speak about the concept of cycle of biomechanical decompensation. This concept is very important to understand because it explains the structural changes that happens in the cornea before the appearance of the ectasia or the keratoconus. And this also explains that the structural changes of the cornea precedes the functional changes. And hence, if we want to establish a screening for ectatic diseases or for keratoconus, we should concentrate on the early detection of the biomechanical changes of the cornea, so that we can determine in early stages the susceptible cases of keratoconus, that we can establish early treatment or even prevention of the occurrence of keratoconus, and also determine those patients who are at risk for any corneal refractive surgery and exclude them from doing that. So the principle of the cycle of biomechanical decompensation started with there is an initial focal weakening. So now the new trend that keratoconus or ectatic diseases is due to focal weakening of the cornea. It is not global or generalized weakening of the cornea. And this focal weakening of the cornea, whatever the cause, this will increase the stress of the intraocular pressure that's present in the eye, will exert stress on this focal point. This is the internal stress factor, because the stress might be internal or external. As I said, the external could be due to rubbing of the eye, continuous rubbing of the eye. However, the internal risk factor is the presence of the intraocular pressure. So the cornea wants to maintain a normal intraocular pressure, so it will withstand the pressure made by this cornea. It will withstand this pressure by the normal tensile strength of the collagen fibers and the normal thickness of the cornea. Once there is focal weakening, so this exert and increases stress on the cornea. And as a result of this, this will lead to a local thinning of the cornea. This will lead to a local thinning of the cornea as a result of this internal stress. And again, this local thinning of the cornea will increase and redistribute the stress made by the intraocular pressure to be concentrated on that area which undergoes both focal weakening as well as focal thickening. And at the end of this, this will lead to compensatory steepening of that point. This point will make steepening and bulging to overcome the increased stress from backward, that's the intraocular pressure. And this will more increase the stress made the intraocular pressure. So as you can see, this is a vicious circle started by a focal weakening due to defect in the biomechanical decompensation or biomechanical derangement in the content of the cornea, and it end up by this steepening. Another thing, it is, as I said, that the structural changes will precede the functional changes. As you can see, even in the stage of biomechanical decompensation, still the vision is very good and very excellent. And as a result of this leading to thinning of the cornea, still the vision is good. At that stage, still the vision is good. And once there is changes in the form of curvature changes and the steepening and the conformation, at that time the vision will drop. So if we want to establish a screening program or prevention program for the establishment of ectatic diseases, if we can pick up the patient at this stage, will be very excellent. That you could become that the stage of biomechanical derangement, so that you can support the cornea or doing, for example, cross-linking or whatever, like the intracorneal rings. They claim that if you implant the intracorneal rings, you will increase the support of the cornea, so you can prevent the thinning and also the bulging of the cornea. So if you want to establish a screening or prevention program, it should be at this level or at maximum at this level. So if you find thinning of the cornea, even the patient is doing well, vision is good, this doesn't mean that if left untreated or unmanaged, he will go and end up by the steepening. And if you depend on the slit lamp for the diagnosis of keratoconus, actually our procedures for diagnosis of the keratoconus taking the reverse step, that we diagnose him by slit lamp, and then we will go and do pachymetry and do topography to determine that there is a thinning or not. And then at the end, we do a mechanical study to determine and discover that the patient has biomechanical derangement. And this is actually very late. This is very late in the management of keratoconus. Now, all patients suspected of being keratoconus or relatives of members of patient with ectatic disease, they should undergo the reverse order like this. We have to do the biomechanical assessment first, then we'll go for topography, and at the end you can find the finding in the slit lamp. So by our understanding for the cycle of biomechanical decompensation, we can know and determine the stages that the patient with keratoconus will pass through to reach to the manifest and overt keratoconus, starting from a healthy cornea with normal parameters. The patient will start with focal elastic property, changes in the elastic property, and still at this stage everything is normal in the patient as far as his vision. Then this elastic changes will become biomechanical changes, and this focal changes in the cornea will start to suffer strain and stress from the internal stress factors. And then after the biomechanical changes happens, the patient will suffer from a subclinical keratoconus that is still not seen clinically and can be only diagnosed by tomography, especially when there is changes in the posterior surface of the cornea, and still the internal stress factor still going on, and maybe still at this stage the visual function is well preserved and the patient will still has good visual function. If the changes is not arrested and still progressing, the patient will have overt topographic keratoconus, and can be detected by topography by changes in the curvature map as well as in the elevations maps. And by this time, the visual function will start to be degraded, and the patient will start complaining of halos around the light and drop in the visual functions, and end up by manifest keratoconus, which is seen clinically by slit lamp and by clinical examination. And our aim in the management of the patient with keratoconus is for early detection. And early detection means that we become early in this stage, that's stage of elastic changes or biomechanical changes, because nowadays we can arrest the progression of the disease by the help of the cross-linking. So if we can pick up this patient at this stage, we can arrest the progression of the disease and spare all these stages. So these are the different stages that the patient with the keratoconus, starting from the elastic changes and biomechanical changes, end up by manifest keratoconus. Now we come to the fourth section of this lecture, which is the clinical examination using the slit lamp to diagnose keratoconus. Now let's come and discuss how we diagnose in details keratoconus. Of course, we will come step by step. The first thing will be the detailed history from the patients and determine whether he is belonging to the high risk group or not. And then we will conduct a detailed clinical examination. And then we will have to do some investigations, especially tomography, topography, and sometimes corneal biomechanics and epithelial mapping. So let's start and speak in details about the history in patient with keratoconus. As far as the history taking, of course, the patient demographic are very important variables. Age usually typically around puberty and progress until 30s and 40s. And according to the CLICK study, which is one big observational study for more than 1,200 cases follow-up for 8 years done in the United States, shows the relative similarity between male and female with mild predominance of males. The CLIC study stands for Collaborative Longitudinal Evaluation of Keratoconus. And as far as the race, they found that the African Americans has higher risk along with Hispanic more than Asian Americans. Now, as far as the symptoms, the common symptoms of a patient with keratoconus is blurring and distortion of the vision. This is seen especially once the changes in the anterior surface of the cornea start to appear. The patient will complain of decrease in the quality of the vision and distortion of the image. Also, sometimes monocular diplopia can be seen. And also, the patient will complain of frequent changes of his glasses. And even the patient, he has reasonable visual acuity, but he is not happy. And also ocular irritations. And in advanced cases, sometimes due to acute hydrops, the patient will have sudden painful drop in the visual acuity due to acute hydrops. So these are the common symptoms of a patient with the history of a patient of keratoconus that we use to ask the patient and elaborate these points. As far as the determination of the high-risk group, by taking history, we have to elaborate whether the patient has history of atopy or allergy or bronchial asthma, and whether the parents are relative to each other or not, and also whether any member in the family having the same problem, or he is suffering from any of the systemic diseases that shows close association with keratoconus. In one study done, they show the risk is increased to more than 1.4 times in patients with ocular allergy and atopy, and people with the chronic eye rubbing, they have 3 times higher risk for developing keratoconus. Also, patients with asthma and eczema and family history, that you can see that the risk increased much more in this group of people. Patients with relative parents, they have 2.8 times higher increased risk. This is one of the studies done shows the prevalence and the risk factor of keratoconus done at 2020. So by history taking, we have to identify whether our patient is belonging to these groups of patients that he has a chronic allergy or atopy, and so that we can strongly confirm the diagnosis of keratoconus based on his strong family history. Now we come to the next step after taking the detailed history and determining the high-risk group. We come to the important step, which is the detailed clinical examination of the patient. Now, when we come to the clinical examination of the patient, now there are plenty of the clinical signs and the clinical findings that we can see, but the main and the hallmark of the keratoconus is the presence of irregular astigmatism, especially if the case is not in the early stages, and the presence of what's known as the Caesar reflex during retinoscopy, and also what's known as the oil droplet sign on the red reflex. When you see by red reflex, you will find what's known as oil droplet sign. This is also among the early features of keratoconus. Of course, you can see by the slit lamp the stromal thinning and also what's known as Vogel's stria and the Fleischer's ring. We will speak about these in details. And also the corneal scarring, and in severe cases you will find the Manson signs. This is very late clinical signs, and Rossotti sign. And sometimes in advanced case you will find acute hydrosis with acute clouding of the cornea and edema and pain. This is the Rossotti sign, that when you throw the light to the temporal side, for example, of the limbus, you will find a wedge shape or triangular shape of the light reflected into the nasal side of the cornea due to the reflection of the apex of the cornea onto the nasal side of the cornea. Now, among the famous signs of the keratoconus is the presence of iron deposition around the base of the cone, which is known as the Fleischer's ring. This should not be confused with the Kaiser-Fleischer ring seen in the Wilson's disease, that one is due to copper deposition around the limbus. However, the Fleischer's ring here in keratoconus is an iron deposition around the base of the cone, and seen clearly with the cobalt blue light that you will find this ring around the base of the cone, due to accumulation of the iron around the base of the cone from the tear film into the cornea. And as I said, it is seen clearly by the cobalt blue light. Another thing is the presence of vagus stria, which is a stress lines. Stress line is present in the descemet membrane and can disappear on gentle pressure on the descemet membrane. They are fine vertical lines. Now, these lines should not be confused with the Haps stria, which is seen in congenital glaucoma. The Haps stria is horizontal in shape, and the vagus stria is vertical in shape. So to memorize them, vagus stria is vertical and Haps stria start with the letter H is horizontal. So vagus stria is seen in keratoconus as a vertical stress lines on the descemet membrane and tend to disappear with gentle pressure on the cornea. Another sign, which is the oil droplet sign, as I said, in the red reflex like this one, is the oil droplet sign, also known as the Charlock's oil droplet reflex, due to when we are doing retinoscopy and there is Caesar reflex, you will see this also oil droplet sign. Sometimes you will see also apical scarring of the cornea and prominent corneal nerves, as you can see here. There will be a prominent corneal nerves. This is not because abnormalities in the nerves, but due to thinning of the cornea. And this is apical scarring of the cornea, which is associated with thinning of the cornea, which can be documented and seen by anterior segment OCT as well. Another important sign in keratoconus is the Caesar reflex sign, which is seen by retinoscopy. When you throw the vertical beam of the retinoscopy, you will find that there is a Caesar, one on the anterior surface of the cornea and one from inside of the eye. So as if there is scissoring of this light reflex. This is a feature of keratoconus and due to high astigmatism. Another late sign of keratoconus is Manson's sign, which is the V-shaped indentation of the lower lid when the patient is looking down. The Rossetti sign, as I said, when the light is thrown into the temporal side of the cornea, there will be a nasal projection of this apex onto the nasal side of the cornea. This is called Rossetti sign. Of course, these are late signs. The most early signs of keratoconus is the presence of Caesar reflex and oil droplet reflex. However, these signs are not early. The Manson sign, Rossetti sign, all these are very late signs for keratoconus. One of the important ocular emergencies in a case of keratoconus is the sudden gush of the aqueous fluid inside the lamellae of the cornea and sudden stretch of the cornea, which will create severe pain to the patient, and severe clouding of the cornea is known as acute hydrops. And this acute hydrops perhaps due to either continuous rubbing of the cornea of this patient, leading to breaks in the descemet membrane, and this will lead to influx and gush of the aqueous inside the lamellae of the cornea with resultant sudden stretch of the cornea, as you can see here. This will create severe pain to the patient. This is regarded as one of the ocular emergencies that should be dealt as quickly as possible. Patient should receive anti-glaucoma treatment and analgesics so that it quietens the cornea and the patient becomes quiet. And usually it will end up by fibrosis and flattening of the cornea. And these patients, they should plan for keratoplasty as soon as possible because they are at risk for another attack. Now we come to the last thing of the clinical assessment after taking the history and determining the high risk group and the clinical examination. Now we come to the investigation. Mainly the gold standard investigation for keratoconus is the topography and tomography. As I said before, that usually keratoconus is diagnosed clinically using the slit lamp as the patient is coming to the doctor complaining of blurred of vision or frequent changes of his glasses. However, sometimes it is diagnosed accidentally when the patient is presented for laser vision correction. As a routine investigation, they do topography or tomography and they discover that they have abnormal corneas or they have subclinical keratoconus, either in the form of keratoconus suspects or form of rust keratoconus. In such cases, they need sometimes to confirm the diagnosis by doing more detailed investigation like corneal biomechanics or epithelial mapping. However, most of the time, as I said, that the cases are simple and can be diagnosed clinically. Now, in the next slides, we will speak in the details in this part on the diagnostic modalities and the keratoconus, which is very important. That is the tomography epithelial mapping, and other investigations that very important to pick up keratoconus in early stages so that we can arrest the progression of the disease. Now we come to the fifth section, which is the diagnostic tools for the keratoconus and treatment modalities. That's the imaging techniques used for the diagnosis of keratoconus. Now we come to an important aspect of this lecture, which is the corneal imaging. As we have spoken before in the lecture of the corneal topography and tomography, that the evolution of the corneal topography from an curvature-based topography to an elevation-based tomography runs through many years, and most of the doctors now they agree that elevation-based tomographies are the gold standard for detection and diagnosis of keratoconus. Now, the tomography is very important for many aspects in the keratoconus, for screening for subclinical keratoconus and for patient for laser vision correction, also for the diagnosis of early diagnosis of keratoconus, and also once diagnosed for the staging of the disease, and finally for the follow-up. So corneal imaging, as I said, starts from the anterior curvatures, that's the Placido-based video keratoscopy. Then it progressed to the use of the Scheimpflug technology, either the basic Scheimpflug technology, that's the Pentacam, or the dual Scheimpflug techniques with the use of artificial intelligence. They add more information about the anterior and posterior elevations, pachymetry, and also keratoconus indices and the enhanced ectasia detections. And recently now they introduced the epithelial mapping, plays an important role for the early detection of keratoconus, either by the use of the swept source OCT or by the use of ultra high frequency ultrasound. So we will speak in details about the epithelial mapping. We already spoken about the elevation-based tomography in the lecture of topography. So we will highlight some important points in the tomography that help us in the early detection of keratoconus. And we will speak about the staging of keratoconus as well as the progression detection. Now, as you know, and as we have spoken in the lecture of tomography, that the main diagnostic tools for keratoconus is the use of elevation-based tomography. However, topography still can be used to determine especially the curvature of the anterior surface of the cornea. And tomography add more spectrum in the early detection, because the earliest changes happens in keratoconus usually happens in the posterior surface of the cornea, which can be seen and detected by tomography rather by topography. Another thing is the study of the corneal biomechanics. Sometimes in suspected cases, as I said, in the subclinical keratoconus or cases with form of rust keratoconus, we need to study the corneal biomechanics. Also, corneal biomechanics, we use it for screening for keratoctasia or for before laser correction. All these tools, the combination of both the topography and the corneal biomechanics increases the sensitivity and specificity for early detection of keratoconus, and also are useful tools in documenting the progression of keratoconus, that we will speak about this in separate slide. Now, what are the different imaging modalities that we utilize to either confirm the diagnosis of keratoconus or for refractive screening for patients who are coming for refractive surgery and you want to see whether your patient is keratoconus suspect or has subclinical keratoconus, or there is any contraindication for the refractive surgery. Of course, the gold standard for diagnosis of keratoconus is the corneal tomography. And I advise you to go to the lecture of corneal topography that we have given before, and to see the different types of corneal topographers available in the market, and concentrate on the corneal tomography that is based on the elevation based technology, and especially the Shanflock technology, because this is very important for early detection in changes in the posterior surface of the cornea. And as the general global consensus on keratoconus and ectasia screening advised that for the diagnosis of keratoconus, there must be a changes in the posterior surface of the cornea. Without the presence of changes in the posterior surface of the cornea, you cannot diagnose keratoconus. Another thing that the gold standard, also the Pellin-Ambroso enhanced ectasia display, which is dependent mainly on the elevation maps, is very important tool for early detection of keratoconus. However, sometimes a false negative cases can be seen in the bad display, especially when the changes in the curvature precedes the changes in the elevations, because it is mainly dependent on the elevation maps. Now we will speak about briefly about the most famous and the gold standard for the diagnosis of keratoconus, which is the corneal tomography and topography. In my lecture regarding this, I have explained the difference between them. And as you know, the general trend now is toward the elevation-based tomography, and after the innovation of the Shanflock technology, and namely the Pentacam, and also the an advancement in the technique of imaging at the occurrence of the enhanced reference surface, as I explained before. For example, this is the picture of the one of the Pellin-Ambroso displays, in which this is the elevation map seen with standard reference surface, and this is the elevation map using the enhanced reference surface. This is the anterior surface of the cornea. As you can see, there is no much changes between the standard reference surface and the enhanced reference surface. However, as you can see, the posterior surface of the cornea, there is island of central thinning or elevations in this part of the cornea, in the posterior surface of the cornea, which get enhanced by using the enhanced reference surface. I will not go in details, as I have explained before about this, and you can go to my lecture regarding the topography and tomography. Generally, we should suspect keratoconus in any patient who have irregular astigmatism, and he has frequent changes of his glasses, and he has a scissor reflex on retinoscopy, and if he has astigmatism more than 5 diopters, or K reading more than 49 diopters, or a pachymetry less than 470 microns, and he has a reduced best corrected visual acuity, and unhappy even with best corrected visual acuity, and with the chronic history of rubbing or allergy. All these are indications to suspect keratoconus in this patient, and we should investigate him thoroughly. And as I said, this is the reference and the link for my lecture regarding topography and tomography. You can go and read in details how to read the topography map. In this slide, I will stress on an important point, that when you look to the topography or tomography map, how to differentiate between astigmatism and keratoconus. As you know, and as you understand from the lecture of topography, the basics of a curvature map and the elevation maps, and we have spoken before that the color code for the curvature map and the elevation map is nearly reversed, but they have the same meaning. So that, for example, this is the sagittal map or the curvature map of a patient with the rule astigmatism. You can see clearly here that the vertical meridian take the red color because it is steep meridian, and the flat meridian takes the blue color because this is the flat meridian. Now the steep meridian here, which takes the red color here in this patient, has the same meaning here, because this, since it is a steep meridian, it is falling below the reference surface in the elevation map, so it has the color of a blue area here. And the flat meridian here, which is in the sagittal map, because it is falling above the flat meridian, so it has the color red color here. So both they have reverse color code, but they have the same meaning that this patient has with the rule astigmatism. This is very important, should be understood. And again here, this is the elevation map, as you can see. This is the meridian which is falling below the reference surface. So it takes the color red, as you can see here, and the map will be in blue color because this is the below the reference surface. And this meridian is falling above the reference surface, so it is falling above the reference surface, as you can see here. Now, the reason why is I stress in this point, because in the next slides I will show you how what's the principle of red on red and red on blue to differentiate between keratoconus case and astigmatism case. Now, after understanding how to read the map, the curvature map, and understand the difference in the elevation map and the curvature map and the color codes for the same data of the patient, this is very important to understand this because it is related to keratoconus. Now, to diagnose keratoconus, we used to say that for the diagnosis of keratoconus, we should have a red on red map. It means that red in the curvature map and redness on the elevation map. For example, if you look to this patient, this is the refractive map or the curvature map. You can clearly see that there is inferior steepening here. There is inferior steepening and takes the color red. And in the elevation map, anterior and posterior elevation maps, both are red. So this is indicate red or red. So this is typical of keratoconus. This is named as red or red. Now, if you look to the case of astigmatism, for example, this patient has the curvature map steepening very clearly and symmetric poti steepening. And clearly this is with the rule astigmatism. When you look to the elevation map, now you find blue color. This is red in a blue. So when you find red in a blue, this is not keratoconus, but this is an astigmatism, as you can see here. So this is just merely with the rule astigmatism and is not a case of keratoconus. That's why we should understand this principle. If you find red or red, that's redness on the curvature map, redness on the elevation map. This is signifies or suggestive of keratoconus. However, if you find red on a blue, this is indicate with the rule astigmatism. Now, I would like to speak about the new concept of the elevation tomography assessment, which is known as the enhancement-based tomography. As you know, the evolution in the imaging of the cornea from the curvature or reflection-based topography to an elevation-based tomography make a new information about the shape of the cornea and overcome a lot of the bias and the assumptions that's made when we extract the shape of the cornea from the curvature map. So we concentrate mainly on the elevations maps, and among the elevation maps, to have an idea about the shape of the cornea and the shape of the cone, we use a reference surface. Now, all of us, we know the standard and the most popular reference surface that's used in most tomography machines, which is the best fit sphere. There is a general agreement between doctors and consensus that an 8 millimeter diameter reference surface is ideal for a quick overview or have a quick idea about the shape of the cornea. As you can see here, this is the best fit sphere, and this is the cornea with abnormalities, so that you can see that the best fit sphere will not exactly and accurately express the abnormalities in the cornea. There is some portion below the reference surface is masked by the reference surface, and only that portion which is above the reference surface which is visible. Now you can see that variations in the size of the best fit sphere or the reference surface will lead to false negative underestimation of the curvature of the cornea due to the prolate shape of the cornea. For example, you can see here in a 7 millimeter diameter, there is a false negative flattening of the cornea. And if you can see here in the other extreme, about 11 millimeter diameter reference surface, there is a false positive steepening of the cornea. And this is a 9 millimeter diameter, it is in between. However, the 8 millimeter is the best used to express the irregularities in the cornea. And moreover, they found that even the 8 millimeter reference surface, it will mask to some extent some of the irregularities of the cornea, as you can see here in this picture. From this idea, another principle which is known as the enhanced reference surface, in which we exclude the central 3 to 4 millimeter from the best reference surface, so that there will be good adaptation of the reference surface to the surface of the cornea, and there will be amplification of the irregularities that is seen on the cornea. That's why it's called enhanced reference surface. Of course, apart from the best fit sphere, there is also the best fit toric ellipsoid and the ellipsoid. They have special indications, especially in abnormal and irregular corneas. But now we are going to speak about the new modality of reference surface, which is known as the enhanced reference surface, invented by Pellin and Prosso in the display, which is known as the BAD display. Now I will explain here how we can study the elevation maps based on the reference surface. As I have said before, that the evolution in the optical imaging from the reflective based technology, that's the Placido disc, to an optical sectioning technology, that's the elevation based technology, that's the Scheimpflug technology, has made the assumption about the shape of the cornea is more accurate as compared to that one made by the curvature map. So we mainly concentrate on the elevations map to have an idea about the shape of the cornea, because sometimes there is some errors and some bias in the curvature map as a result of the alignment and the angle of kappa. However, this is not the case in case of elevation-based technology. Now, if you look in this example, this is an abnormal or not abnormal cornea. This is a astigmatic cornea in which the horizontal meridian, as you can see here, is steep. So if we see the shape of the cornea in relation to the reference surface, this is the best fit sphere. So the horizontal meridian, which is denoted in the red color, is falling below the reference surface. That's why it has the red color. And the vertical meridian, which is denoted in the blue, is located above the reference surface. So this is against the rule astigmatism. You can see that the central point, there is no elevation because this is the point of touch between the cornea and the reference surface. And the paracentral areas has a large positive values, which doesn't reflect the elevations, but this is because this is an astigmatic cornea. And these values represent the distance or the difference between the steep and the flat meridians. Now, if you look to the other example, this is another cornea which is typical of keratoconus. You can clearly see a central area of island surrounded by blue sea, and this indicate that this is highly elevated above the surface of the cornea, surrounded by a green zone, which is the interface or the intersection between the reference surface and the conical cornea. If you can see here, this is the bulging part which is seen in this island, which is highly elevated. You can see the large positive values here. And this area of intersection between the reference surface and the cornea will be in green color. And this is the mid-peripheral part, which is falling too much below the reference surface here. And you will find here also again another contact between the reference surface and the cornea. So you will find another ring of green color here. So this is typical of keratoconus in relation to the reference surface, which is the best fit sphere. Now, if we compare this with the recently evolving, as I said, the enhanced reference surface, by understanding the meaning of enhancement, so that this is the best fit, as I said, that there will be masking of the irregularities of the cornea. However, in the enhanced reference surface, we deduct the central 3 to 4 millimeter from the reference surface, and this is of course done by the computer system of the machine, and so that the reference surface at the periphery and mid-periphery will be co-opted to the surface of the cornea, and there will be amplification of the irregularity, and it will be very clear. So any subtle case of corneal irregularities or subclinical keratoconus or form of rust will be evident by this maneuver. This is invented by Pellin and Prosso, and this is now the new principle that's used for screening for any irregularities and ectasia in the patients using the Pellin and Prosso, mainly screening for refractive cases that you want to do LASIK for them. So better to apply these principles to determine whether he's at risk for ectasia after laser or not. This is the what's meant by enhanced reference surface. By enhancement, it means that we amplify the irregularities by deducting the central 3 to 4 millimeter, and so that we compare the cornea with the enhanced reference surface rather than with the best fit sphere. Now in this example, we will see how we apply the enhanced best fit sphere to amplify the finding the surface of the cornea. For example, as you can see here, this is utilizing the regular best fit sphere, utilizing an 8 millimeter diameter, so that you can see that there is an area of steepening in this area of the cornea. And this is the reference surface. As you can see, it will hide some part of irregularities of the cornea because it takes 8 millimeter diameter zone. Now, if we apply the same cornea with a reference enhanced best fit sphere, so it excludes the central 3 millimeter from the reference surface. So now you can see clearly that the amplification of the steepening of that part of the cornea as compared in this slide. So this is the reference surface, which becomes the enhanced reference surface, and the amplification of the irregularities of the surface of the cornea is very clear. So it is clearly that the use of the enhanced best fit sphere will help in the early detection of keratoconus and any irregularities of the cornea that might be hidden by the standard reference surface. The second important imaging tool in the corneal, in the corneal diseases, which is the segmental tomography made by the anterior segment OCT and the evolution of what's known as the epithelial mapping. And this was because of the advancement in the anterior segment OCT, so that the details description of the corneal epithelium has been made after the evolution of the anterior segment OCT. As you know, the normal corneal epithelium remarkably is uniform all over the cornea, and hardly you will find very mild difference, just in a few microns. And the difference mainly between superior and inferior superior and inferior part of the cornea because of the blinking. Also, you will find the temporal cornea is more flatter than the nasal cornea, and this is maybe because of the tarsus. So there is the distribution of the corneal epithelium between 50 to 60 microns, with being thicker in the inferior part of the cornea as compared to the superior, and thicker in the nasal part as compared to the superior to the temporal. And this asymmetric distribution, as I said, mainly due to blinking of the lid, and also the slightly elevated tarsus or canthus in the medial part as compared to the lateral part. Now, the another thing is that the epithelium has an active remodeling activity that masks the underlying stromal irregularities to produce a smooth and symmetrically optical outer corneal surface. That's to say that if you have thinning, there will be a thinning over the elevated or any steep part of the cornea, as seen in keratoconus and in hypermetropia. As you know, when we apply laser ablations to the mid-peripheral part of the cornea, the central part will become more steeper, so that might be associated with some thinning of the overlying corneal epithelium. Or you will find thickening over the tissue removed by the laser ablation itself that lead to flattening, as seen in myopia, or in the mid-peripheral part also of the hypermetropia. So this remodeling feature of the corneal epithelium plays an important role in determining the thickness of the epithelium, so that it will be thin over elevated or steep cornea, and it will be thick over flat cornea or over scarring. This is very important feature. Utilize it to pick up early cases of keratoconus. Now, as I said before, that the typical appearance of the epithelial mapping in a case of keratoconus is the what's known as the donut pattern. Donut pattern means that there is area of thinning of the epithelium. As you can see here, I will show the pointer. This is area of thinning denoted by the color blue, and surrounded by annulus of hot colors. As you can see here, the yellow-red color is the isthmus or annulus of hyperplasia of the epithelium over the central part of the cone, which is shows thin cornea. So this is very important typical picture seen in patients with keratoconus. Another advantage of the epithelial mapping is to differentiate between false ectasia from true ectasia. The false ectasia typically seen in a corneal warpage syndrome. For example, if you can see this patient with pachymetry, and this is the epithelial mapping, you can see clearly that the epithelium is uniformly distributed. However, the inferior part, there is hot colors which indicate thickening. However, when you see the topography of these patients, the area of hyperplasia is not corresponding to the ectasia or bulging of that this part of the cornea. This is the sagittal map, showing asymmetric porti with inferior steepening. So we expect that in this area it will be thin cornea. However, in the epithelial mapping, you find it hyperplasia and thick epithelium. So this indicates that this is not a true ectasia. This is a corneal warpage syndrome due to contact lens wearers. So just to remind you that the epithelial mapping technique has added another spectrum for the early detection of keratoconus, especially in suspected topography and suspected tomography. By this way, we can confirm the diagnosis of keratoconus. Also, it is useful tool in refractive screening. Now, as I said, that the epithelial mapping and the picture of the epithelial mapping in keratoconus is suggestive of keratoconus, but is not pathognomonic unless it corresponds to the another signs, that's elevation on the posterior surface of the cornea. For example, if you can see in this slide, this is the elevation map showing the hot spots here with elevation on the posterior surface of the cornea, and this elevation corresponds to the thinning of the epithelium on the epithelial mapping. Now, this is very diagnostic for keratoconus, and if we see this in a 9mm mapping of the epithelium, this is area of thinning. So this is very diagnostic for keratoconus, that when you find two signs that's thinning correspond to the elevation on the posterior surface of the cornea, this is very pathognomonic for keratoconus. So the epithelial mapping add another useful tool in the early detection of keratoconus and very useful screening tool for refractive screening. So now we understand that the typical appearance of the epithelial mapping in the case of keratoconus will be the donut pattern. And by donut, we mean that there is a focal area of thinning over the apex of the cone, surrounded by area or zone of hyperplasia, as you can see in this one. This zone of or isthmus of hyperplasia is known as the donut pattern, and this donut pattern is suggestive of keratoconus and became only pathognomonic if it is supported by similar changes in the posterior surface of the cornea. If you have typical changes in the posterior surface of the cornea suggestive of keratoconus with a corresponding changes in the epithelial map, this will be pathognomonic for keratoconus. So the epithelial mapping is very important tool for early diagnosis of keratoconus. And the idea is that the dynamic on the remodeling process of the corneal epithelium behave like that whenever there is depressions or there is a valley, it will hyperplasia and thicken. And if there is any elevations, the epithelium over the elevations will be thin and become more thinner. So we utilize this advantage to confirm the diagnosis of keratoconus. And all of these informations of the remodeling of the epithelium should be understood along with the other clinical signs. So all are added together to reach to the final diagnosis of especially subclinical keratoconus. Now we come to the third modality of corneal imaging in keratoconus, which is known as the dynamic imaging of the cornea, or studying the biomechanics of the cornea. And this is accomplished by deformation of the cornea using air, and then we study the physical properties of the cornea. And the idea came from the fact that some cases they have normal tomographic map, and upon examining the physical property, mainly the elasticity and viscosity of the cornea, they found it abnormal. And based on these criteria and indices, they could determine the high-risk cases for heterogeneous keratoconus following laser vision corrections, or cases with form of rust keratoconus. So biomechanics is the science that study the equilibrium and deformation of tissues submitted to any force. And as you know, that the anterior 40% of the cornea has twice the biomechanical property as the posterior surface of the cornea. That's why we are concentrating, especially in cross-linking, to make the posterior part of the stroma more stiffer than normal, so that to prevent the progression of keratoconus. The cornea is a viscoelastic structure that has a viscous property and elastic property. in which the collagen fiber is responsible for the elastic property, and the matrix of the stroma is responsible for the viscous component. And elasticity defined as the property of substance to change in length or volume or shape in response to the force. However, the viscosity or resistance is a property of the substance to change in shape due to internal friction between molecules, like in the honey. Now, for the detailed information about this subject and the biomechanical properties and the dynamic imaging of the cornea, I suggest for you to go through my lecture regarding the corneal biomechanics, in which I spoken in details about the different machines used in the detection of the corneal biomechanical properties, and the different indices like the CBI and the TBI, and the integration of the biomechanical property with the tomography. Now we come to the fourth way of imaging in keratoconus, which is the study or the analysis of the wavefront, and study and analyze the wavefront apparitions seen in patients with the keratoconus. As you know that keratoconus, apart from having an irregular astigmatism, it also the patient complain of having high order apparitions, mainly originated from the cornea, and this may contribute to the decrease and degradation of the visual quality of the image in the patients. And the most common high order aberration seen in patients with keratoconus is the vertical coma, trifoil and tetrafoil, and secondary astigmatism. Now, the analysis of this high order aberration, the wavefront of this high order aberration, will aid in the early diagnosis as well as in the follow-up of patients with keratoconus, and also in advanced cases of keratoconus. By studying the high order aberrations, we can achieve what's known as objective refraction, in which the standard refraction may be difficult in these patients, so we can have an objective refraction by studying the wavefront analysis for these patients. So what I want to say that the causes of visual degradation in patients with keratoconus, it is not just only the irregular astigmatism and the irregular cornea that lead to decrease in the visual acuity, but also it is the high order aberrations as well as the low contrast of the image. Because of this high order aberrations, the image quality will be of low contrast, and this all contribute to the decrease of the quality of vision of patients with keratoconus. Now, this era of studying the wavefront analysis of patients with keratoconus is the cornerstone for the doctors to suggest to what's known as the topography guided high order aberrations ablations, and the wavefront guided high order aberrations ablations. And as you can see here in this example, among the management of patients with keratoconus is the use of scleral contact lenses, and they utilize the wavefront from the eye of patients with keratoconus to customize a special wavefront guided scleral contact lens, so that you can see the improvement in the image quality. This is by using the traditional scleral contact lens, and you can see the point spread function is still not a single spot. And with the use of the wavefront scleral contact lens, you see how much the image quality has been improved, and much improvement in the root mean square and the point spread function. So analysis and studying the wavefront of a patient with keratoconus is a very useful tool in early detection as well as in the follow-up, as well as improving the image quality. Now, the aim of our management in patients with keratoconus is not just to increase the quantity of vision, but also we improve the quality of vision. Our aim is to stabilize the patient first, then we improve the surface of the patients and the irregularities of the patient, and at the end we will have reached to the final goal, which is improvement in the vision as a quantity as well as quality. Another new modality in the investigation of a patient with keratoconus, or the imaging in a patient with keratoconus, is to study the wavefront and determine the aberrations in the wavefront, and also determine the high order aberrations. Now, basically or initially, the wavefront analysis was designed to study or to plan a customized laser vision correction. However, now with the advancement in the techniques and the machine that can study the details of the wavefront, we can utilize this technology not only in planning a customized laser correction, but also to diagnose abnormalities in the surface of the cornea and the topography and alterations in the surface of the cornea, namely in keratoconus. So we use the wavefront analysis both in diagnosing keratoconus, also for planning a customized treatment, as we will explain later on, what's known as the topography guided ablations or the wavefront guided ablations in patients with keratoconus. Now, as you know that among the visual degradation that happens in a patient with keratoconus and decrease in the quality of the visual function is because of the presence of high order aberrations. And the aim in the management of these patients in keratoconus not to offer them spectacle-free vision or improve their vision to 6/6, but also a big achievement if we can improve the quality of the vision of these patients by reducing or eliminating the high-order aberrations. So studying the wavefront analysis is very important in these patients, both from diagnostic point of view as well as for planning the modality of treatment for these patients. As you know that the normal wavefront, this is the normal wavefront when confronted with a aberrated abnormal cornea or irregular surface of the cornea. This will be reflected back by the aberrations and defocusing that happens in the retina, and the wavefront will be aberrated. And patients with keratoconus, as you see, like in this patient, they commonly the most common aberrations is vertical coma, trifoil and tetrafoil, and secondary astigmatism. And by studying the wavefront, we study what's known as the Zernike polynomials, as we have spoken before in the lecture of the wavefront analysis about the Zernike polynomials. As I said, that the most common is the vertical coma. This is the vertical coma. You can see when we study the point spread function, this is the patient, how the patient will see this single spot of light as aberrated spot, like here. And this can be measured and explained by different methods. The most common is by representing these aberrations or the deviations of the wavefront from the normal spherical typical wavefront to an aberrated wavefront by the root mean square. Now, the root mean square explains or describes the deviations of the normal wavefront to the aberrated wavefront in micrometers. So this is what's meant by the root mean square. So I will not go in details to speak about the spherical, about the wavefront aberrations. I advise you to revise my lecture regarding the Zernike polynomials and the wavefront analysis. However, what I want you to know that we utilize this technology both in the diagnosis as well as in planning the treatment for patients with keratoconus. Now we come to the fifth type of imaging in keratoconus, which is recently invented, is what's known as the polarization sensitive OCT, abbreviated as BSOCT, or it is an ultra high definition OCT for the cornea. And this is mainly or precisely describes the imaging of the collagen fibers in the stroma. As you know that in keratoconus, the main problem is in the collagen distribution and the density and the orientation of collagen fibers in the stroma. And even with the available current imaging techniques in the form of ordinary OCT or the tomography machines, still there are some cases that even anatomically proved to be normal, even with the dynamic studies and the biomechanics, but still they develop post-LASIK ectasia and heterogeneous ectasia. And this raises the question that the risk for ectasia, there is another mechanism hidden behind all these imaging techniques that's still not recognized. And this brings the doctors to the new area of investigation and imaging, that not only assessing the gross anatomy of the cornea in the form of the tomography and topography, but also going into the details of the molecular level and imaging the collagen fibers in the stroma. So the polarization sensitive OCT based on the principle of the birefringence. And this birefringence means is the optical property of the material that result in double refraction based on the angle of incidence and the polarization state of the optical axis in relation to the interface. the idea that they discovered that the collagen fibers in the stroma has a birefringence property. And this birefringence property means that the refractive index is not fixed within the tissue, but it has more than a refractive index, and this will result in a double refraction. And as a result of this, there will be splitting of the rays and polarization of the rays in a vertical plane and in a horizontal plane. And based on the difference between these two polarization planes, there is a special detectors in the machine that can recognize this difference, known as the retardation difference. And as a result of this, a ultra high definition details of the tissue can be determined based on this imaging technique. So this property is available in certain structures. One of them is the collagen fibers, and the speed of light is not the same in all the direction. As you know that the speed of light from the principles of the Snell's law, the speed of light is dependent on the refractive index of the material. And since the birefringence material has a more than refractive index, so there will be more speed of light, different speed of light within the materials, and hence the different directions. So that's why it is named as double refraction, that you will have more than refractive index, more than refraction, and that's named as double refraction. And the birefringence, this is a feature of the birefringence property. The unpolarized light, when it passes through this birefringence material, will split into two planes, polarized rays, and the different polarization with different polarization speeds and divergence. And measuring the difference between these two rays will give the detailed molecular structure of the tissue. Now, this is just a quick representation of what I have said, that if you have a light polarization sensitive light that passes through a birefringence material, now this birefringence materials will allow the light to pass only in the x of the direction of the polarizations, and the light will be split into a vertical and in the horizontal plane. So based on this splitting, they can have more information on the molecular level about the structure, and these rays will be detected by special detectors, and you will have a high resolution image. So as I have mentioned before, that the polarizations is an optical property of the material that has the ability for double refractions or the birefringence. So when there is a polarization sensitive light thrown into the cornea, all the light will pass through the cornea, but except the stroma, because the stroma is full of collagen fibers, which has the birefringence property, and detected this birefringence property that lead to splitting of the light is detected by special detector. And as a result of this, we can have around 11 millimeter image of the epithelial map, which is a real map, not extrapolated as in ordinary OCTs. Also, we will have details about the Bowman's membrane thickness, which is the first time that we can have a detailed thickness of the Bowman's membrane, and also a retardation map for the collagen density and orientation in the stroma, that you will have an in-face image of the stroma related to the density of the collagen fibers and the orientation. And based on this map, we can decide whether this patient is suspected for being keratoconus suspect or not. All this came from the idea that ectasia can be driven by other factors other than the gross anatomical features seen by topography and tomography, and beyond the dynamic imaging of the cornea and the biomechanics. So as you can see here, this is the collagen fibers. As the light polarization sensitive light passes through it, so it has the birefringence property and leading to the splitting of the light based on the axis and the orientation of the rays, and picking the difference between these two rays, and the determination of the retardation difference between the two split rays will gives information about the molecular level or the structural property of this tissue. And as a result of this, as I said, we will have a spectrum of images. We will have a large size 11 millimeter epithelial map, and we will have another map showing the details of the Bowman's membrane and also about the stromal thickness and the property based on the orientation and the density of the collagen fibers. As you can see here, this is the Bowman's membrane thickness. You can see this picture shows a very thin Bowman's membrane, and as you know, the importance of the Bowman membrane and the integrity in maintaining the stiffness of the cornea, and also its role in the pathogenesis of keratoconus. And this image shows a thick Bowman's membrane that he is not at risk of developing keratoconus as in this patients. Now, the problem that arises that, as you know, that sometimes even with topography and corneal biomechanics and the CBI and the TBI, you will find the normal topography and or tomography and abnormal CBI and TBI and so on. All this dilemma makes it necessary to have another tool to determine the difference between these patients, and that's why the doctors are looking for this mode of investigation, which is the ultra high definition OCT, or what's known as the polarization sensitive OCT, to determine the orientation and the density of collagen fibers within the stroma and correlate it with the clinical finding. Now this project is still going on, and still data is collected to determine the database for this technology, and accordingly it will be utilized in the future for screening for keratoconus and also for refractive surgery. Now, as you can see in this slide, this is a theoretical representation of the distribution of the collagen fibers, and this is how the in-face image can be seen representing the stroma. Now, the darkness of the blue color indicates the compactness and the orientation and the distribution of the collagen fibers. The more the blue color means more compact and more dense collagen fibers, and this is less blue color indicate less compact and less the heavily distributed collagen fibers. So the utilization of this technology will help for early detection of keratoconus based on the distribution of the collagen fibers and the orientation of the collagen fibers. Now, this is the picture. For example, we have, this is a normal patient, this is a form of rust keratoconus, and this is a keratoconus patient. This is the traditional tomography maps that you can see. This is a normal patient, and this is a form of rust and the keratoconus. Now you see the in-face image for the retardation map for the stroma. This is the retardation map, which reflects the density and the compactness of the collagen fibers. You can see here clearly the dense blue color indicate dense compact collagen fibers. This is a lens dense compact collagen fibers, so it is concise to the form of rust keratoconus, and this is very clearly that was very loose collagen fibers here seen in a typical case of keratoconus. So by utilizing this technology, as I said, this is very useful in early detection and for refractive screening for keratoconus or heterogeneous ectasia. Now, recently, the use of AI or the artificial intelligence in the clinical field has very wide applications, especially in ophthalmology, because of the pattern detection in ophthalmology and the number of images that we depend mainly on a large number of images, either topography, tomography, and the corneal biomechanics, and also the electron microscopy and the collagen imaging in the form of polarization sensitive imaging. All these data make it difficult for us as a clinician to memorize and categorize your patient whether he's a good candidate for such type of treatment or not. So the introduction of artificial intelligence, namely the neural networking, has aided the doctors to a large extent to classify and diagnose the case, as well as to choose the ideal modality of treatment. Now, the artificial intelligence, starting from the basic machine learning to the advanced machine learning, and then to the what's known as the deep learning or the use of the neural networking, utilizes need all the information of the patient to be fit to the system in the form of pictures, topography, tomography, all the nomograms, all the NDCs needed for the patients, the indication and the contraindication for intracorneal rings or the contraindication of cross-linking. All this data should be fed to the machine, and the machine, through special activation process, it will integrate all these informations and come up with the final conclusion regarding the modality of treatment or also the diagnosis of the case. So the artificial intelligence is a type of artificial intelligence, as I said, using the neural networking is a very useful tool in the field of ophthalmology. Now the idea, it is similar to the neural cells in the human being, that you have an input zone. This is the input zone in which all the data is fed to the system. Then the activation of the process of the intelligence will be triggered here in this area, and then we will have the final output and the result either in the form of diagnosis or choosing the modality of treatment. The disadvantage of this way that it need to feed the machine with a huge number of information before the machine can be able to take the final decision instead of the human being. So you need a large data to be fed to the system so that the machine will learn how to take the diagnosis, how to take the decision, and so on. There are many examples of the applications of the artificial intelligence in the field of ophthalmology, namely the neural networking. For example, all the softwares seen in the topography and tomography, they utilize the artificial intelligence for extracting the indices and determine the suspected cases of keratoconus. Also, the nomograms for the intercorneal rings and the cross-linking, all they utilize the artificial intelligence as well. Similarly, the softwares for the optical response analyzer and the keratoconus screening softwares, all they utilizes the same principle. And also the Corvus biomechanical index, the CBI, and the integration with the tomography, that's the TBI, also based on the artificial intelligence. And also now there is incorporation of the Bellin-Ambroso enhanced ectasia display and the ABCD classification system incorporated with the artificial intelligence to determine the people who are at risk of progression. So the applications of the artificial intelligence in popular or general acceptance by most of the doctors, and is incorporated in most of the recent machines that utilize it in the detection or diagnosis or the management of keratoconus. One of the applications of the use of the artificial intelligence in the field of ophthalmology is the introduction of the what's known the SBK, which is stands for the Simple Mobile Affordable Reliable Technology, in which the mobile phone is fixed on a portable tomographer, so that it will be useful in the screening of a large number of populations, and the system will select the high suspicious cases, so that you will concentrate on them, and from them you will decide whether these patients are going to have keratoconus or not. Another way of the artificial intelligence now currently available is the KeyDob software, which is a keratoconus early detection platform that also, based on the data you feed to the system, it can help you to early detect cases of keratoconus. Now we reach to the sixth section, which is the evolution in the early detection of keratoconus and also the clinical grading and the progression of keratoconus. We will study in details this part because it is very important for understanding the clinical grading of keratoconus as well as determining the progression of keratoconus. Now, after finishing speaking about the enhanced reference surface and its applications in the early detection of keratoconus, now we will come to speak about important evolutions in the keratoconus detection and grading, and also in the progression of the detection of the progression of keratoconus. Now, the applications of this enhanced reference surface came initially in the Bellin-Ambroso display. We will speak about the Bellin-Ambroso display, and also we will speak about the ABCD staging or grading system. And then finally, we'll speak about the ABCD keratoconus progression detections. So we will go one by one and speak about the Bellin-Ambroso display, and we know its importance in the early detection of keratoconus. Now, after we finish speaking about the enhanced reference surface and its application as use it in the ectasia screening, Now we come to one of the important applications of the enhanced reference surface, which is the Pellin-Ambrosio display, or the bad display. This bad display made up of different components, the elevations maps, the anterior and posterior elevation maps using the standard reference surface and the enhanced reference surface, along with the subtraction map, and also the thickness profile, so that we will study each section of this display separately. Now we will study the first part, which is about the elevations, anterior and posterior, using both the reference surface as well as the ectasia or the enhanced reference surface for ectasia screening. Now, as far as we are speaking about the Pellin-Ambrosio display, before I explain about the maps, that I would like to remind you that the bad display is not specific for keratoconus, and it is best applied for screening for refractive corneas. That's before doing any laser vision corrections. This cornea should be screened using the bad display, and to determine whether this is a normal cornea or abnormal cornea. And abnormal cornea does not mean necessarily that he is going to develop keratoconus, because these corneas might be subclinical, or what's called for me frost keratoconus. So they will be stationary unless you interfere with laser vision correction. At that time, there might be an iatrogenous keratoconus. So what I want to say that the Pellin-Ambrosio display is not specific for keratoconus, but it helps you to differentiate between normal and abnormal cornea. Hence, it is best application is for refractive screening to eliminate or exclude corneas that are suspicious. So if you can see here, the first row shows the corneas using the standard reference surface using the best fit sphere. This is the anterior elevation, and this is the posterior elevation maps. The second row represents the after applying the enhanced reference surface. This is the anterior, and this is the posterior surface of the cornea. And the third map is a subtraction map. This is not a real map. This is generated by the computer or the machine that subtract the changes between the reference surface and then the enhanced reference surface. And the horizontal row here with different colors will show you the statistical significance of the difference, whether it is falling into the green zone or in the suspicious yellow zone or in the dangerous red zone. As you can see here, if the difference map between the two maps here, the standard reference and the enhanced reference surface, fall in this area, so it will be in the green area. And if it is suspicious, it will fall in the yellow area. If it is dangerous, it fall into the red area. As I said before, that this does not mean that this is a keratoconus, but this indicate that this is an abnormal cornea. Better not to go for laser vision correction for them. This is the main advantage. The other thing that by using the enhanced reference surface, we study, as I said, that we study the cornea after applying the enhanced reference surface, so that we amplify any minor irregularities in the cornea using this technique, which is generated by the computer after exclusion the central 3 to 4 millimeter from the cornea. Now, if we apply these to the these maps, you have three maps, as you can see here. For example, the leftmost one, after we apply the Pellin-Ambrosio display, this is using the enhanced reference surface. You can see a very minor elevations here eccentrically, and get enhanced after using the enhanced reference surface. And this is a subtraction map, shows the difference between the two maps, but it's still within the yellow area, which is the suspicious zone. Now, if you look to the second maps, or in the middle, the same thing that we apply the same principles, and you can see clearly the difference between the elevations within the standard reference surface and the enhanced reference surface. This is on the elevations map and the anterior surface, and this is on the posterior surface. And the subtraction map, you can see clearly the difference between the anterior, the elevations map in the posterior surface, and as well as in the anterior surface. But in this time, it falls into the red zone, which is dangerous or suspicious, surrounded by a yellow zone. Now, this is advanced case of keratoconus. You can see clearly here that the red zone after the subtraction map is much more than the middle one. So it applies the same principle. So better for this patient not to go for laser corrections. And as I said, that for early cases, you cannot say that this is a keratoconus, but better not to go for any laser vision corrections. Now, after finishing speaking about the first portion of the Bellin-Ambroso display regarding the elevations maps, now we will come to the second portion, which is the thickness map or the bathymetry map, and we will speak about the thickness profile and the spatial thickness profile. The thickness profile, which is the second portion of the Bellin-Ambroso display, describes the changes in the corneal thickness within the first 6 millimeter zone, and study the profile of thickness starting from the thinnest point of the cornea in a concentric rings up to the periphery. And we have two varieties. We have the what's called the corneal thickness spatial profile. This is the corneal thickness spatial profile, and the percentage thickness increase. This is the percentage thickness increase. This percentage thickness increase is nothing, just the same like this, but we represent the information as a percentage. Now the central or the corneal thickness spatial profile, this is between two confidence intervals, the 5 and 95 confidence interval. As long as this profile falls within these two tram-like lines, this indicates that the progression profile of the thickness of the cornea is normal. Now, if any deviation beyond these two lines, this indicates that there is abnormality. Similarly here, as you can see, this is the normal cornea, as the corneal thickness progression or spatial profile falls within these two confidence intervals. Now, if you have a keratoconic cornea, you can see that the red line is a border line that's falling below this one. Before the 6 millimeter zone, it dropped down before the 6 millimeter zone. Now, it's very important that to follow the line up to the 6 millimeter zone. Now, this is, for example, the reverse. This is a mild oedematous cornea. So there's the thickness of the cornea. So you can see that the line is flat, and this is very advanced corneal edema or Fox endothelial dystrophy. So the line may go beyond the first confidence interval and becomes very flat, as you can see here. So this provides very important information about the progression profile of the cornea, starting from the thinnest point of the cornea, which is not necessarily on the apex of the cornea, and towards the periphery. And this is very important principle because the Bellin-Ambroso display changes the concept of before we were using the what's called the absolute value of the corneal thickness or the bathymetry. Now they discovered that it is not just purely the thinnest location that determines the susceptibility of the patient for any laser vision correction, but it is the spatial profile, the distribution of the thickness from the thinnest point towards the periphery. Now, if this is profile is abnormal, this is will be suspicious even if the thickness of the cornea is within normal limits. So this is very important. Now we come to the last and the final portion of the Bellin-Ambroso display after we finish speaking about the elevation maps and the different elevation maps and the progression thickness profile. We come to the conclusion that's the final 5Ds and the final D, which is the standard deviation for each of these parameters, and see the final result of this map. So we will speak now about the standard deviation or the 5Ds for all these variables and these parameters. Now, as I said before that, in the second version of the Bellin-Ambroso display, they added to the maps the result or the interpretation of the different variables, and this is denoted by the letter D and represented by different functions, and these D represent the standard deviation for this variable. For example, we have 5Ds. DFF stands for front, that's the standard deviation of the anterior elevation changes, and the B stands for the back surface of the cornea, the same thing, the standard deviation of the back surface of the cornea, and the P stands for the bathymetry progression, and T for the thickness at the thinnest point location, and the Y stands for the displacement of the thinnest point along the Y-axis. Although the last point is not heavily weighted, as you can see that in the Lepelin Ambroso 3, he has eliminated this function, and the deviation of the thinnest point along the y-axis is not heavily weighted. And this we will explain it later, because sometimes there is what's known as nibble con, so you can see advanced keratoconus with minimal displacement of the thinnest point along the y-axis, so that this point is not heavily weighted, and in the Pelin Ambroso 3 has been eliminated. Now, what I want to say that in the first version of the Pelin Ambroso display, there was no these D functions, but in the version 2, they have added the D functions, so that the map itself will gives you different Ds, and then at the end it gives you a final D, as you can see here. So these the final functions, as I said before, if you find it in the yellow, it indicates this is suspicious or borderline, and if it is red, it is abnormal. And then you have another final D. Now this final D is not the average for these 5 Ds, but it is a separate by regression analysis. It takes in consideration all these 5 variables, but for you as a clinician, you have to concentrate on this final D, and your decision should be based on this final D, not based individually in each one. Sometimes you find this is suspicious, but this is normal, so you take this as a normal. Now the cutoff value for this D function is 1.6. If it is less than 1.6, it will be in the white, I mean normal range. If it is between 1.6 to 2.6, it will be in the yellow range. And if it is beyond 2.6, it will be red and abnormal. And I repeat again that the final D is not the average for these 5 Ds. It is a separate D that's taken by regression analysis and reflects the changes in each of these 5 variables, concentrating mainly on the changes on the posterior elevation maps. Now, this brings us to the third version and the latest version of the Pelin Ambroso display, which is the third version, which is currently available. What they did, they have added another 4 parameters to be taken in consideration in the map and represented here in this section of the map. These variables include the elevation at the thinnest point. They eliminate or they cancel the deviation along the y-axis of the thinnest point, but they added the elevation of the thinnest point. And then the Kmax, because this is a very popular parameters, but although we have spoken before that the Kmax is not sensitive parameter for determination of the progression of keratoconus, and it mainly reflects the changes in the anterior surface of the cornea. Another thing is the ART max, the Ambrosio relational thickness, and also the ability to choose between hyperopic data database or myopic database, so that if your patient is myopic, you should not compare him with hyperopic database and the reverse. Now, if your patient is hyperopic, you should select from this area. There is an option to choose between hyperopic database or myopic database. And also, they added an option to keep these D functions or they eliminate them. This is just for medico-legal reasons. So this is the final version of the Pelin Ambroso display. They have added some functions here, but these functions are not included in the regression analysis of the final D. This is very important. Now they have added this function, and you have to look for them. You will find the red flag or the yellow flag, but these parameters, they are not included in the regression analysis of the final D. Now, for example, this is a case of advanced keratoconus. You can see that this patient, all the Ds, they are red in color, including the final D, and the newly added parameters also in the red zone. So this is totally abnormal patients, and this patient indicates that this is abnormal cornea that should not, or he's not candidate for any laser vision corrections. He's at risk of developing ectasia after laser correction. Now, after finishing speaking about the Pelin Ambroso display, now we come to the second step, which is the ABCD staging system, and we will discuss the importance of this new grading system for keratoconus. Here in this slide, I will give a quick overview of the history of the grading of the keratoconus. Before we speak about the recent grading or classification system of keratoconus, we will come quickly through the simple review for the history of grading of keratoconus. Generally, there is no general agreement or there is no clinically adopted classification for keratoconus even till now. The most famous classification system, which is known as the Amsler-Kromak classification, initially made by Amsler, then Kromak he made some modification, and then it is named by Amsler-Kromak classification at 1998. This is one of the most commonly and widely used, and the disadvantage of this system that it is not consistent. That in the classification, for example, he classified to grade 1, grade 2, grade 3, grade 4 based on the keratometry reading, based on the central corneal thickness, and also based on the refraction and the clarity of the cornea. However, sometimes you find advanced keratoconus with advanced K reading, but you find a clear cornea, or you find early keratoconus with high refractive errors, so that you cannot know whether you put it in stage 1 or stage 2 or stage 3 and so on. So this is one of the main disadvantages of the Amsler-Kromak classification. Also, it depends on the K reading, especially in the K max, which is only reflect the changes in the anterior surface of the cornea. And as you know that in keratoconus, the earliest changes will appear in the posterior surface of the cornea. So sometimes you have advanced progression of keratoconus without much changes in the anterior surface, so you find the Kmax is not that changes. The other one, a classification which is made by Aliao Shabai classification at 2006, the same as Amsler Kromak classification, but he added the high order operations, provided that in keratoconus there is usually coma, vertical coma, and the high order operations, so that you can notice that he added the root mean square here, and he added the high order operations in the classification. But the same thing that sometimes you find, as I said, that early keratoconus as far as the K reading, however, you find high order operations. So it is not consistent all the time. The other classification, which is made by Ritix classification at 2011 with the help of George Aliao, and this is in Spain, and they incorporated the best corrected visual acuity as a functional classification among keratoconus, not just only the refraction of the patient, but also the best corrected visual acuity. And also it incorporates what's known as the internal astigmatism. Now they assume that there is no much contribution of the lens in the astigmatism. So by internal astigmatism, they defined it as the by subtraction the manifest astigmatism from the anterior surface corneal astigmatism. So the residual astigmatism will represent the posterior corneal surface. And as you know, the posterior corneal surface is the first to be affected in keratoconus, neglecting the contribution of the lens in the internal astigmatism. So, and also they added the sphericity factor at 9 millimeter. So the classification, as you can see here, it includes the K reading, the best corrected visual acuity, the internal astigmatism, and the Q value, and the coma, and the high order operations, and so on, similar to other things. But the same thing, as I said, that it is not consistent all the time, because sometimes you find early keratoconus, but you find advanced high order operations or root mean square. So you get confused whether to place the patient in grade 1, 2, 3, and 4. The other thing that in these classification, all of these classification, there is no clinical relation with the management. I mean, there is no clear-cut values for management of stage 1, management of stage 2, 3, and 4, and when to do cross-linking or not to do cross-linking, and so on. And the other thing that in the last Ritix classification, as I said, that the values are not fixed. You'll find a gap interval. For example, this is stage 1, so you find that this is the range of the internal astigmatism up to 2.114. Then the next stage will start from 2.18. So there is a gap between these two values. So this makes some errors. Here in this slide, I will mention some of the disadvantages and limitations of the Amsler-Kromak classification. Why I concentrate on this? Because this is one of the most famous keratoconus grading and staging system, which is still used till now. The first limitation that it mainly relies on the keratometry and namely the K-max and also in the apical pachymetry of the cornea. And as you know that the K-max or the keratometry of the anterior surface does not represent the true state of the keratoconus, as the changes on the anterior surface of the cornea is very late stages because the earliest changes will appear on the posterior surface of the cornea. Also, the apical, based on the pachymetry of the apical part of the cornea, which does not really describes the keratoconus. As you know, in the keratoconus, the apex usually of the cone is displaced inferiorly. So when we take the pachymetry of the apical part of the cornea, this does not reflect the pachymetry of the apex of the cone. So this is one of the limitations of the Amsler Chromax. The other thing is that it completely ignores the posterior corneal surface. Mainly, it depends on the anterior surface of the cornea, and this is a major drawback of it because the earliest changes will appear in the posterior corneal surface. Also, it offers confusion in the clinical correlation. For example, if you can see, this patient is 35 years old with a apical pachymetry of 485, which so it falls in the stage 2, and it has a mean K reading of 54, so it falls in stage 3. However, he has a refraction of -3, so it should be false in the stage 1. So you don't know that whether to classify this patient as to be in stage 2 or stage 3 or in stage 1, as you can see here. So the Amsler Chromax is not consistent with the all finding of the patients, and this make a lot of confusion, so that you don't know what's the next step in the management of this patient, whether you are going to do cross-linking or you are going to interfere surgically or you want to observe the patients. So this is among the confusions of the Amsler Chromax classifications. Another thing or another example, if you can see here, similarly, this patient, we have two patients, 18 years old patients with a pachymetry of 410 and a mean K reading of 52 and refraction of -8 diopter, and this will be classified as to be in stage 2. Similarly, if you see this patient of 47 years old with a pachymetry of 544 and a mean K reading of 48 and refraction of -5, so you can notice the difference and the huge difference between the refraction between these two patients, and both of them are classified as stage 2. So the classification does not really reflect the real state of the patients, and also it doesn't assess the functionality of the patients because it doesn't include the best corrected visual acuity. It depends only on the refraction objectively. Now, because of the major pitfalls of the Amsler Chromax grading system that has been identified, especially that it mainly concentrates on the anterior surface of the cornea, neglecting the importance of the posterior surface of the cornea. Also, it concentrates on the pachymetry of the apical part of the cornea, not in the thinnest point on the apex of the cone. Also, because of there is no clinical correlation between the staging and the modality of management or treatment, especially the cross-linking. All these points make the need for a new grading system is very important, and this came from the global consensus on keratoconus and ectatic disease meeting that made in 2015. And this contains the four supranational corneal societies, the ASEAN Cornea Society and the Cornea Society of the United States of America, and the Eurocornea and the Pan Cornea Latin of Latin America. All these major national ophthalmology societies, they meet at 2015, and they make some recommendations. One of the important recommendations is that for the diagnosis of keratoconus, the abnormality in the posterior elevations of the surface of the cornea should be documented. Also, the abnormal corneal thickness distribution rather than buoyant thickness of the cornea. There should be a abnormal distribution, the thickness pattern or profile of the cornea. Also, they concentrate that although clinical inflammations or the diagnosis or the definition of keratoconus, that it is non-inflammatory disorder, and this term is to describe the clinical inflammation in the form of redness and itching and pain and so on. However, a low-grade inflammation can be present in patients with keratoconus, which is not seen at a clinical level. So, as we have explained before, that in the theory and the etiology of the keratoconus, a low-grade inflammation can be existing, and this will stimulate the certain mediators of the inflammation that lead to changes in the molecular level of the collagen fibers and the matrix, and this can initiate the process of thinning and ectasia. So although the definition of non-inflammatory disease is referring to the clinical inflammatory signs, but this doesn't mean that there is no low-grade inflammation at the molecular level. Also, the recommendation of this general or global consensus that the best current available way for diagnosing keratoconus is by the use of tomography rather than topography. By tomography, we mean that we depend on the elevation-based tomography, especially the Shamflock technology, and the posterior corneal elevation abnormality must be present to diagnose early subclinical keratoconus. So from this meeting, all the global national society of the ophthalmology, they agree that they need for a new classification system that overcome all the pitfalls that the Amsler-Krukmak grading system has fallen in, and they start saying that we need to stop using the Amsler-Krukmak classification system. And from that time, the new classification will appear. That's the ABCD grading system by Pillen. I will speak in the next slides about this new classification system. Now we come to the latest classification of the keratoconus, the staging and the grading system made by Mr. Pillen at 2016. And the aim was to improve the pitfalls that Amsler-Krukmak grading system has fallen in, especially that it concentrates on the anterior surface data, only neglecting the posterior surface data. And also in this new grading system, it will concentrate on the thinnest point of the cornea, not in the apical thickness of the cornea. And it has a very good clinical correlation with the modality of treatment. And it has also included the best corrected visual acuity. So the ABCD stands for, the A stands for the anterior radius of curvature of the cornea, the anterior radius curvature of the cornea over 3 mm zone on the thinnest locations. And the B stands for the same thing on the posterior surface of the cornea. And the C stands for the pachymetry, but not on the apical cornea, but on the thinnest location of the cornea. And then the distant corrected visual acuity. And another modifier has been added, which is the corneal scarring, if there is a scarring or no scarring, or mild scarring or severe scarring. So this is the Pillen classification is mainly dependent on the Pillen Ambrosio display, and this parameters has been generated by the software of the machine and is mainly dependent on the pentacam. Now, this is one of the disadvantages of this system, that it is dependent on the system, because this system is available only in the pentacam system. Another thing, that when they measure the best corrected visual acuity, it doesn't include the best corrected visual acuity using the hard contact lenses, but it is based on the use of the glasses only. Now, if we look to the details of the ABCD system, you can see that they have included a 0 stage, which doesn't mean that this patient is normal, although his visual acuity is 20/20, but still he has some suspicious cornea that may be diagnosed as subclinical or form first keratoconus, so it helps in the early detection of keratoconus. Other stages 1 to 2, 3, and 4, same like the Amsler-Krukmak system, but it depends on the radius of curvature rather than in the keratometry, and this is very important. Make it more accurate and reduce the need for any assumptions for the power of the cornea, and this is a very good representation for the power of the cornea. As you know, the posterior surface of the cornea is a negative meniscus and negative lens, so by using the radius of curvature, this will overcome the assumptions that made to understand the power of the cornea. And about the pachymetry here, it relies on the pachymetry over the thinnest point of the cornea on the apex of the cone, not on the apex of the cornea. And as I said before, the distant best corrected visual acuity, this is not generated by the machine, but it is added by the doctor himself, and then they add the scarring system. And based on this grading system, as you can see here, this is the ABC grading system. You can see the result will come like this. For example, this patient has a very minimum anterior changes in the radius of curvature of the anterior cornea, but he has a significant changes in the radius of curvature of the posterior cornea. So an early changes appears, the earliest changes in keratoconus appears on the posterior surface. So although he has very minimum changes in the anterior surface of the cornea, and also he has a good visual acuity, as you can see, 20/20, because the anterior surface is intact, but he has significant changes in the posterior surface as well as in the thickness of the cornea. He has thin cornea, so the grading will be A0, B4, C3, and D0. This is will be seen in the pentacam display on the Pillin ABCD classification section. Still in the context of the ABC grading system, as I said before, that it has a very good relation with the clinical application, especially in relation to the cross-linking. Now, if you see this, for example, this grading system, A2 stands that average changes in the anterior, the radius of curvature of the anterior surface of the cornea, but very early changes in the posterior surface of the cornea. So this patient has +2 scarring of the cornea with marked drop in the visual acuity due to D4. So this patient is appropriate to have a DALK procedure. However, when you look to this patient, similarly, he has advanced changes in the anterior surface of the cornea, with advanced stages in the posterior surface of the cornea, with very thin cornea, and also his visual acuity is poor, and he has a corneal scarring, so he is a good candidate for penetrating keratoplasty. Now, if you look to this patient, he has no scarring of the cornea, and he has a very good potential visual acuity, although he has moderate changes in the anterior and posterior surface of the cornea. So this patient may be suitable for intracorneal rings or fitting of a hard contact lenses, because there is no scarring of the cornea. So you can see that there's a close relation between the grading system and the clinical application to choose the best modality for treatment for the patients. And as I said before, the drawbacks of this ABC system, that only it is dependent on the pentacam, and it doesn't take in consideration the best corrected visual acuity using the rigid gas permeable lenses. Still in the context of the evolution in the keratoconus detection and the grading and the progression system, we finished the Pillin-Ambroso display, and we finished the ABCD staging system. Now we come to the third step, which is the ABCD keratoconus progression detection. This is very important in the documentation of the progression of the keratoconus. Now, first of all, before speaking about the ABCD progression system, we have to define the meaning of ectasia progression. Now, currently, there is no any constant or clear definition for ectasia progression. Ectasia progression is defined mainly by consistent stage changes in at least 2 of the following parameters, where the magnitude of the change is above the normal noise of the testing system. So at least 2 of the following 3 points should be available to document the presence of progression. Number 1, presence of steepening of the anterior corneal surface, or presence of steepening of the posterior corneal surface, and thinning or increase in the rate of the changes in the thickness of the cornea from the periphery to the thinnest point. So at least 2 of these should be available before we can document or say that there is an active progression of the disease. Now, another important point, that we are not concentrating in a single bathymetry or the central bathymetry as a determinants for progression, but we rely on the progression profile of the thickness of the cornea from the periphery to the thinnest point. So the thickness of the central part of the cornea is the least determinant parameter that can be used to determine progression. We shouldn't rely just only in the central bathymetry, but we should rely on the progression profile of the thickness of the cornea, as we have explained before in the PAD display. This progression profile from the thinnest point to the periphery is very important. Another thing that although the progression is often accompanied by decrease in the best spectacle corrected visual acuity, however, the changes in the visual acuity is not required to document the progression. So we should not rely on the changes in the visual acuity to document progression, because there are many background variables playing that affect the visual acuity of the patient with keratoconus. So we should keep it in mind, but we shouldn't depend on it to document the progression. Another thing that rigid gas permeable lenses, although they are agreed as one of the best modalities for the management of keratoconus, but it is approved that they don't slow or halt the progression of keratoconus. So this is very important information. You should keep it in mind, especially that at least 2 of these 3 variables should be documented before we can say that there is a progression, and it is the progression profile of the corneal thickness and not the central pachymetry that is we depend on. Now, this is just summary for what we have said just now, that the documentation of progression needs 2 of these 3 variables should be documented before you say that. Here in this slide, I would like to remind you about this important fact that central pachymetry is the least reliable indicator for progression of keratoconus. And this is for 2 reasons. The first reason that, as you know, keratoconus, the thinnest point is corresponding to the apex of the cone. And the apex of the cone most commonly is not present in the central part of the cornea. It is present paracentral. And when you rely on the central pachymetry, you might have a false negative result, as the central thickness does not reflect the apical thickness over the apex of the cone. Another thing that we don't rely on point thickness on the central or paracentral part of the cornea, but we rely mainly on the progression profile of the thickness from the central part towards the periphery. This progression profile is very reliable as compared to the point thickness that's either in the center or in the paracentral part of the cornea. So when we want to study the case thoroughly, we have to rely on the progression profile of the thickness rather than point thickness in the cornea. And as I said earlier, that the central pachymetry does not reflect the pachymetry over the apex of the cone. Is a progression. Now, as far as keratoconus, it is known that keratoconus is a progressive disease, and documentation of progression is important in order to choose the best determinant or the best mode of treatment, and also for the follow-up of the patient. Now, this is very important because keratoconus is a progressive disease, so it is not just the early detection or the treatment that we need to offer to the patient, but also we have to document the progression of the disease so that we can arrest the progression of this disease. Exactly like in the case of glaucoma, it is not just enough for you as a doctor to just diagnose the case of glaucoma and you give your patient the treatment, but you should follow him to document whether your patient is stable under your treatment or he is still in a progression, and your job is to stop the progression of the disease, not just giving the treatment. Now, as far as the progression, none of the available criteria, which is based on the following parameters that I am going to mention now, are accurate or reliably can be regarded as a gold standard for the documentation of the progression of keratoconus. And the main reason lies that the disparity in the diagnostic tools and the lack of acknowledged on the kinetic progression of keratoconus, like asymmetric kinesia. What I mean by this, that the disparity between the diagnostic tools, now the topography taken from one machine system cannot be compared with another topography taken or tomography taken from another machine. So they are incomparable, and disparity between, for example, Pentacam and Orbiscan and so on. So this is one reason that we can, when you face the patient in the clinic and he has a topography or tomography from one system, you cannot compare it with your system, which is, for example, Pentacam. This is one of the reasons that make the current progression criteria is not reliable. Another thing, the presence of what's known as the very asymmetric ectasia, and this make confusion between doctors to document the progression, because sometimes you find a patient with unilateral ectasia and the other eye is completely normal, and these people they need not to progress to the clinical keratoconus. They might stay for a long time without any evidence of progression unless they undergo laser vision corrections or any surgical interventions. So the lack for this knowledge for the kinetic progression of keratoconus, or the trigger factor for the progression, is also another important obstacle that facing doctors to exactly determine who's going to be progressing to keratoconus and who's will be stationary. And for this reason, there are certain important high-risk factors that you should keep it in your mind, so that if you find a patient with these high-risk factors, you should follow him closely. Number one, if you have a young patient at the diagnosis, young people, they have a high risk for progression, so you have to follow them very carefully. Also, any patient with post-laser treatment, they should be follow up. And if you find any changes, as we have mentioned before, so you have to regard him as a progression for keratoconus. Another thing, people with habitual eye rubbing, they are at high risk for progression. And also people with genetic factors and genetic predisposition. As we mentioned before, the relation of keratoconus with certain syndromes and certain diseases and the presence of positive family history. This is another important high risk factors that you should keep it in your mind. If you have a patient with a positive family history of keratoconus, you should follow him closely for the evidence of progression. The last thing is the hormonal factors during pregnancy. If you have a woman that she's going to get pregnancy and she is known for, to have a keratoconus, you should advise her that the pregnancy and the hormonal changes can lead to progression of keratoconus, and you should follow them carefully, so that at least you plan for a cross-linking immediately after delivery. Now, the question of the safety of the cross-linking during pregnancy is not approved. However, there is no documented evidence that cross-linking will lead to any problems during a pregnancy. However, it is not advised and generally agreed between doctors that in a pregnant lady, better not to expose her to a cross-linking. So all these are high-risk variables that you should keep it in your mind in the presence of a patient with suspected keratoconus, that you should follow them very carefully. As you know, this is the general natural history of the keratoconus, that it will progress, especially from childhood during puberty, and progress over the adulthood, and eventually by the third and fourth decade, due to the ultraviolet and auto or natural cross-linking, there will be a stop or arrest of the progression of the disease. And just keep in mind that keratoconus is a bilateral disease, and it might be present asymmetric, and it is a progressive disease. That's why this are very important to diagnose keratoconus, that you should keep in mind that your patient might be progressing, and we need to have an accurate progression grading system, so that we can document the progression and arrest the progression at exact or the right time. Here in this slide, I will speak about the some of the old accepted parameters that are used to document the progression of keratoconus, and they say that at least 3 parameters should be concurrently present to document the progression of keratoconus. Number 1, increase in the Kmax more than 1 diopter in 1 year, or increase in the manifest cylinder more than 1 diopter in 1 year. Also, the deterioration of the best corrected visual acuity within 1 year, and thinning of the cornea at the thinnest location more than 5% in 6 to 12 months. Another thing is the increase in the spherical equivalent more than half a diopter, or increase in the mean K more than 1.5 diopter in 1 year. And lastly, changes in the contact lens power over 2 years. As I said, that this is the current or the old progression system, and at least 3 parameters should be present before documenting progression of keratoconus. However, generally, this criteria is no more accepted by most of the doctors as they adopt the new ABCD progression system, because all these parameters are dependent on the anterior surface of the cornea, and the changes in the anterior surface of the cornea are very late changes, and by that time the patient will have advanced disease before documenting the progression. Another thing that, as you know, the earliest changes will appear in the posterior surface of the cornea, and also the reliance on the reliance on the best corrected visual acuity is not a sensitive parameter, as there are many variables affecting the visual acuity in a patient of keratoconus. So generally agreed between doctors that this is an old system and no more accepted, and we are in need for a new classification or grading system for the progression of keratoconus. For that reason, the development of the ABCD progression system appears. And as I said, why the old system is not accepted? Because it is relying mainly on the Kmax, which is a bad or poor indicator for the progression, because by that time, advancement in the disease will take place before any minor changes in the anterior surface of the cornea, because the Kmax mainly represent the changes in the anterior surface of the cornea. Also, the changes, the reliance on the changes in the visual acuity is not sensitive parameter, as it is a subjective parameter affected by many variables, and also affected by the level of the apparitions the patient is suffer. And as you know, the level of apparition in keratoconus is not a linear proportional relationship with the severity of keratoconus. Sometimes you have a very mild keratoconus with very high significant apparitions, and sometimes you have advanced keratoconus with minimum apparitions. Another thing is the old system, the reliance on the objective refraction is not consistent all the time, especially in advanced cases of keratoconus, where it will be impossible to get the refraction of the patient. But for that reason, the global consensus, as I said before, of keratoconus that's made at 2015 with the meeting of the major 4 national ophthalmology societies, they acknowledge the need for the new progression system to fill the gaps in the current system for the assessment of the progression of keratoconus. And at that time, and 1 year after, the ABCD progression system has been developed by Pillin. So the ABCD progression system, or the Pillin ABCD progression system, designed specifically to follow and document the progression of the disease based on a one-sided confidence interval. We will speak about this later. And it allows the documentation of the progression in spite of stable anterior chamber or stable Kmax, and it evaluates each layer by layer. So it is a topography dependent display that document the progression of keratoconus layer by layer. This is very important because it documents the progression in the anterior surface of the cornea, posterior surface of the cornea, and also in the thickness of the cornea. And also it determines, based on the tomography, the statistically significant changes among these layers. So it is very useful tool to document the progression of keratoconus. As you can see here in this slide, this is the display, or this is the second release of the ABCD display, and the 4 parameters, the A, B, C, D. A stands for the changes in the anterior surface, curvature of the anterior surface. B stands for the changes in the posterior corneal surface, the curvature, and the C stands for the changes of the thickness of the cornea over the apex of the cone, and the D stands for the distant best corrected visual acuity, and this is not generated by the machine, but this is placed by the doctors. And as you can see, the display can present up to 8 exams at a time. The first exam is used as a baseline exam, and then at different exams is displayed here so that you can compare whether there is progression or there is a stationary disease. Layer by layer, as I said, that each layer individually is displayed, and there is a confidence interval. The green flags refers to the comparison with the normal population, and the red flags comparison with the keratoconus populations. and the confidence interval between 80 to 95 confidence interval. So the dotted line indicate 80% confidence interval, either a green flag or red flag, and the straight line indicate the 95 confidence interval. And as we said that this is a single-sided confidence interval. That's to say that these variables, they have only one option. That's the anterior curvature of the cornea. If it is increased in keratoconus, there is no chance to increase or decrease. It will be increased, so it is one-sided interval. Also the posterior surface of the cornea, also the corneal thickness, it will not increase, but it will decrease. So this is a one-sided interval. According to the changes in each layer of them, we can decide whether your patient is stable or on progression. For example, if you can see in these patients, the baseline exam and the initial exams, they don't cross the red flag of the keratoconus populations. However, this is on the anterior surface of the patients of the cornea. And if you see the posterior surface of the cornea, it is much more passing beyond the red flag, both for normal population and keratoconus population. So in the second and third visits or assessment, there is progression of the disease over the posterior surface of the cornea, although the anterior surface there is no significant changes. And that's why you can notice that there is no much changes in the visual acuity of the patients. And also, this indicates that the Kmax, there is no much changes in the Kmax in this patient as compared as the changes mainly appears on the posterior surface of the cornea. You can see here in more details. So this is the 4 layers, the importance of the ABCD progression display, that it assists each layer by layer the topographic changes and determine the statistically significant changes on each layer based on the single-sided confidence interval, comparing these changes with the normal population and keratoconus population, and accordingly we can determine the progression of the disease, and also can determine what's wrong with this patient. Is it in the anterior surface or posterior surface or in the thickness? Now, as I said earlier, that we have to compare the data recorded from the patient with the data stored in the system, either with the keratoconic population or normal population. Now, if your patient is old patient and has a clear evidence of keratoconus, and there is no risk of weight, so we compare his data with the keratoconus patient data, which is flagged as red. And if he crossed the confidence interval, which is between 80 to 95%, and these changes are beyond the noise level of this calculation, so we regard that this patient is abnormal and he has a progression. Now, if your patient is young patient with a subclinical disease or form of frost keratoconus, and the risk of weight is high, so in these patients we compare them with the normal population, which is flagged with the red flag. And the same thing if they cross the confidence interval beyond 80 to 95%, so regarded as that there is a progression. So the importance of this to document clinically significant progression at whatever layers of the cornea, the anterior surface or posterior surface or the thickness of the cornea. Similarly, we can separate, for the noise, so that the display is not noisy, so we can display and choose the option from the software that if you have a young patient, you just want to display the normal population flags like this, or if you have an old patient, you can choose to display only the keratoconic patient database, and you compare the result of your patient with this database. Now in this slide, I will speak about the confidence interval, because this is important to understand. As you can see here, we have the green flags to represent the normal population, and the red flag represent the keratoconic populations. You have to choose which population you want to compare the data of your patients. And if you pass the confidence interval beyond the 80% confidence interval, indicate significant changes. As you can see here, the line which is in straight line, this is the indicate the 95% confidence interval, as you can see here, and the dotted line indicate the 80% confidence interval. The green indicates normal population, and the red indicates keratoconus population. Similarly here, the dotted lines indicate 80% confidence interval, and the straight line indicate the 95% confidence interval. So if your patient cross the 85 confidence intervals up to the 95, 80% confidence interval up to 95 confidence interval, this indicates significant changes, and you have to take an action, and you need to decide which type of modality you need for your patients. So this is, you can see here, this is the 80% confidence interval, and this is the straight line, this is the 95% confidence interval. Now, as I said before, that using the ABCD progression system has clearly covered the pitfalls and the shortage of the using of the Kmax, as many times that there might be a dissociation between the clinical progression with the changes in the Kmax that you find. There is no changes in the Kmax, however, there is significant changes in the cornea, mainly in the posterior surface of the cornea, based on the ABCD progression display. So the ABCD display is an important topographic-based classification system that recognizes the changes in all layers and display and document the statistically significant changes. So this is very important to understand. Now, if you look for this example, this patient is a stable, has a stable anterior surface of the cornea. As you can see, he has different visits, and the first visit is used as a baseline. That's why the dotted line here indicate this is the baseline visit. And when you see the subsequent visits, the changes in the anterior surface is very little, and he's comparing it with the keratoconus population. He is not reaching up to the 80% confidence interval, so this is regarded as stable as far as the anterior surface of the cornea. However, when you look to the second parameter, that's the P parameter, that's the changes in the posterior surface of the cornea, especially in the third and fourth visits, it significantly cross beyond the confidence intervals of 80%, as you can see here, especially in the fourth visit. And also the changes in the thickness of the corneal profile has been much crossing the 95% confidence intervals, although the Kmax, as you can see here, is completely stable. And that's why the reliance on the Kmax to determine the stability of the cornea is not accurate way. So the ABCD system is very accurate in documenting the changes in the cornea layer by layer. Now, this is an example of a young patient, 16 years old patient. You can see clearly here as far as the A variable. Since he's a young patient, we will compare him with the normal population database. So he significantly passes the 95% confidence intervals as far as the A variable. And similarly for the P variable, he passed the 95% confidence interval. And also for the C variable, which is the thickness of the cornea, he passed the 95% confidence interval. So in this example, there is clear-cut evidence of progression, although or in spite of the stability of the Kmax. That's why we say that we shouldn't rely on the Kmax to document progression, because it is very late sign. Now, if you look to the other example, this is an old patient with evidence of keratoconus. Since he's old, so we will compare him with the keratoconus populations. So we will concentrate on the red flags. As you can see here, that the baseline measurement here in the yellow color, and then after that 2 consecutive visits, he exhibits very clear evidence of progression, although it doesn't pass beyond the 95% confidence of the keratoconus populations. But over the next 2 consecutive visits, there's documented clear progression. This is also need urgent interference, and this is very clear evidence of progression, and this patient need to be interfered, otherwise he will be at trouble. And such patients, they need to do cross-linking, although they have an old age, but these patients indicate that even they need a cross-linking to arrest this progression. Now this shows the third version of the Pillin ABCD progression display, and the third release of this software incorporate the confidence intervals for before cross-linking. So you can see the blue flag here signifies that the patient underwent cross-linking, and this is the time for the cross-linking. The horizontal line here indicates the time for interventions, and another 2 visits after the cross-linking. So you can see and compare your patient data with the normal population, keratoconus population, and also with after cross-linking, and see whether your patient is stable or not. Now, for example, if you can see, this is patients with who underwent cross-linking. He's a young patient, 16 years old. And since he's young, we compare it with the normal population. As you can see, we can choose to display only the green flags for the normal populations. And this is the line for the cross-linking. This is the baseline visits. And this is the consecutive visits after the cross-linking. You can see clearly that this patient is stable, and he's doing well after cross-linking. He doesn't pass beyond the 85% confidence intervals. So he's doing well with cross-linking. This is another example for another patient. Similarly, as I said, that the horizontal dash line here indicate the time for the cross-linking, and the other 3 consecutive visits. This is after the cross-linking. This is the cross-linking session, and other consecutive 2 visits below. You can see that the patient, as far as the parameter A, has passed beyond the 95% confidence interval. Similarly, for the parameter P, he passed the 85% intervals. No much significant changes over the C parameter, which is the thickness of the cornea. So this patient may need to do retreatment or another cross-linking to make him more stabilized and stationary. By now, we have finished the first section of comprehensive guide keratoconus. I hope that you have benefited from the information mentioned in this lecture. I would like to thank you for your patience, and I also thank all the people who helped me to arrange this material. And I remind you that the next portion, we will speak more in details about the treatment modalities in keratoconus, ranging from spectacles and objective refraction and contact lenses, cross-linking, intracorneal rings, and refractive surgery in keratoconus. And the last is keratoplasty and how we approach a case of keratoconus. Thank you very much. And I would like to remind you that the keratoconus day is on the 10th of November each year. Thank you again.